Hey there, sleepyheads. Settle in, friend. Dim the lights, pull a blanket close, and let the world go quiet for a little while. Tonight we're wandering into a corner of the Middle Ages that sounds shocking to modern ears, but made perfect sense to people who lived by hearth smoke and candle glow. This is a gentle story about why vomiting was once prescribed as healthy, how physicians thought it balanced the body, and what it tells us about a world guided by humours, seasons, and the slow wisdom of routine. You'll hear about apothecaries grinding potent herbs, monks debating disciplined diet, and feast halls where rich food met worried stomachs. We'll keep the tone soft and curious, less gross out, more why did they believe this, so you can relax, learn, and maybe drift a little as we go. Before we begin, I'd love to meet you in the comments. Where are you watching from? What's the weather like outside your window right now? And what's your cozy snack or sip tonight? Tea, cocoa, something crunchy? If you enjoy slow, soothing dives into the stranger habits of history, tap subscribe and turn on the little bell so you don't miss the next candlelit chapter. Ready? Take a breath. Let the past open like a door on old hinges, and step with me into a time when doctors looked to the stars, the seasons, and, yes, the stomach, to keep the body in balance. In medieval learned medicine, health was understood as a state of balance among four bodily fluids, or humours: blood, yellow bile, black bile, and phlegm. This framework, inherited from classical authors such as Hippocrates and Galen and transmitted through late antique and Arabic medical writing, defined disease as dyscrasia, a disorder in the mixture or quantity of these fluids. Restoring eucrasia, the right proportion and quality, was the central goal of therapy. One of the most important families of interventions for re-establishing balance was evacuation, removing excess or corrupted humours from the body. Physicians recommended different routes of evacuation depending on which humour they believed was in surplus and where it was located. Vomiting belonged to this toolkit as a controlled reset, particularly for problems thought to originate in the stomach and upper digestive tract. The logic began with digestion. Medical texts describe digestion as a staged process of cooking, coction, in which food was transformed into nutriment and then into blood. If the stomach's fire was weak, or the meal was heavy, cold, or mixed badly, the result was crudities, partially cooked residues that generated vapours, blocked passage, and corrupted humours. Symptoms such as nausea, a sense of fullness, headache, foul breath, coated tongue, or disturbed sleep could be interpreted as signs that the stomach held harmful matter. In this model, compelling the body to expel that matter upward made sense. Emesis promised to remove the offending material before it further decomposed, entered the bloodstream, or altered the overall humoral mixture. Humours were also linked to qualities, hot, cold, and wet, dry, and to organs and seasons. Blood, hot and wet, was associated with the liver and spring, yellow bile, hot and dry, with the gallbladder and summer, black bile, cold and dry, with the spleen and autumn, and phlegm, cold and wet, with the brain, lungs, and winter. Physicians believed environmental changes, diet and lifestyle could tip these qualitative balance. A hot, oily feast in summer might stoke bile, a cold, damp routine in winter might thicken phlegm. Evacuation was therefore not random, but tailored. Bleeding for a sanguine excess, laxatives or clysters for downward removal of phlegm or black bile, sweating for certain fevers, and vomiting when undigested material or sharp bilious accumulations were suspected in the stomach. Texts emphasised timing and indication. The right moment to purge was when the offending matter was still in the stomach or had recently formed there. Many regimen guides advised early morning on an empty stomach, when the body could expel without competing processes. Seasonal purges, often spring and autumn, were framed as preventative maintenance, clearing residues left by the previous season and preparing the body for the next. At the bedside, physicians assessed complexion, pulse, stools, urine, and the patient's narrative of meals and symptoms to decide whether emesis was the appropriate route. If the problem appeared lower in the gut, a downward purge was preferred. If the trouble was higher, upward evacuation was chosen. Balance by evacuation also involved proportionality. Removing too little changed nothing. Removing too much risked weakening the patient and provoking new imbalances. Dosage and strength mattered. When recommending vomiting, learned authors typically paired the act with a set of guardrails: mild methods for the frail, stronger for the robust, caution in children, pregnant women and the elderly, avoidance during certain fevers or when the patient was already dehydrated. Aftercare, light broths, warm spiced drinks, rest was part of the same balancing logic intended to stabilize the system after a disruptive intervention. Morality and medicine intersected here but were not identical. Preachers condemned gluttony, yet physicians differentiated between vice and therapeutics by motive, timing and supervision. A purge ordered for specific symptoms, administered in measured fashion and followed by corrective diet fell within medical necessity. The same act performed to enable more indulgence or done to excess could be criticised as moral failure and medical folly. That distinction reflected the broader medieval concern with moderation. The means and the measure determined whether evacuation restored balance or created new disorder. Finally, evacuation was rarely a standalone fix. It belonged to a package called regimen, encompassing food, drink, sleep, exercise, bathing, and emotional management. The physician who ordered vomiting for post-feast crudities also adjusted the patient's diet, warmer or cooler foods, simpler preparations, advised on portion size and meal timing, and sometimes prescribed walking or gentle sweating to support digestion. The aim was not to empty the body for its own sake, but to remove what impeded proper coction and circulation so that subsequent meals could be processed into healthy blood. In that sense, emesis functioned as a reset button within a comprehensive program of balancing inputs and outputs, qualities and seasons, with the hoped-for outcome of a steady, well-mixed body. Continuing from that broader regimen approach, the choice among evacuation routes was not arbitrary. Medieval physicians weighed location, quality and quantity of offending matter, the patient's constitution and timing. Vomiting, upward evacuation, was favoured when the trouble was judged to be in the stomach or immediately above it. Recent surfeit, incomplete digestion, crudities, or sharp bilious accumulations rising from the upper gut. If the evidence suggested the burden lay lower in the intestines, a downward purge, lenitive laxatives, stronger purgatives or clysters took precedence. When signs pointed to a general fullness of hot blood, plethora with heat, a flushed face, bounding pulse, and inflammatory pain, bleeding was the primary choice to remove quantity and reduce heat quickly. Clinical heuristics anchored those decisions. Upward evacuation was chosen when patients reported early morning nausea, sour eructations, foul breath despite recent tooth powder, a heavily coated tongue, frontal headache worsened by rich food, and a sense of weight or stop in the epigastrium. These were read as markers of material retained in the stomach that, if not expelled, would corrupt and spread. By contrast, constipation, lower abdominal cramping and flatulence with delayed stools pointed physicians toward downward remedies. High fevers with a strong tense pulse, throbbing temples, and redness or swelling suggested an excess and heating of blood. In such cases, phlebotomy could precede or replace purgation. Quality of humour mattered as much as sight. Yellow bile, hot dry, produced sharp, burning sensations, bitter taste, and yellowish vomitus. Emesis directly removed that corrupt bile before it diffused. Phlegm, cold wet, generated sluggish digestion and mucus. Texts often advised softening or attenuating phlegm first with oxymel, honey vinegar, or warming spices, and then sending it downward with lenitives rather than provoking a violent upward effort. Black bile, cold dry, implicated in chronic stubborn disorders, was rarely addressed with emesis. Instead, milder, repeated purgatives and dietary regimen were preferred to avoid provoking dryness and weakness. Constitution, age and season supplied further filters. Robust, warm and moist bodies were thought to tolerate vomiting better than lean, dry or elderly patients. Children and pregnant women were generally steered away from strong emetics because of the risks of strain and dehydration. Seasonal logic followed humoral correspondences. Spring, aligned with blood, often brought bleeding for sanguine plethoras. Autumn, linked with black bile, favoured purgation. Emesis appeared in spring and autumn regimens, chiefly as a corrective after feasts or during transitional clean-outs, while many authors cautioned against it in the depths of winter, too cold and weakening, or in the driest heat of high summer, risk of exhausting moisture. The practical pharmacology also shaped choices. Upward evacuation required specific agents or techniques: warm salted water, feather stimulation of the fauces, or pharmacological emetics such as white hellebore or squill, substances that carried recognised hazards if dosed improperly. Downward evacuation offered a broader gradient, from gentle lenitives, prunes, diacatholicon electuaries, cassia polypody, to stronger purgatives, senna, colocynth, scammony rhubarb, and clysters, enemas that could localise effect to the lower bowel. Because bleeding needed only lancets, bowls, and a practised hand, it was fast and decisive, but also the most depleting. Physicians considered not just theoretical fit, but what a household or apothecary could safely supply and monitor. Sequencing was another lever. Many regimens began with a period of coction, diet, rest, and warming simples, to ripen humours before any strong purge. After large meals that produced obvious crudities, emesis could be ordered immediately without waiting for ripening, on the argument that the offending matter was still in the stomach and not yet mixed into the blood. In acute hot conditions, some authorities bled first to blunt heat and prevent complications, then purged downward once the patient was safer. The overall aim was to change the patient's internal state with the least collateral harm, remove what was excessive or out of place, then restore gentle processing by appropriate foods and routine. Risk-benefit calculus was explicit, even if framed in humoral terms. Vomiting offered rapid relief when the problem truly sat in the stomach. It could abort headaches or vertigo believed to rise from gastric vapours. But it carried costs: strain, risk of syncope, drying of the throat, and exacerbation of underlying weakness. Laxatives worked more slowly and, if chosen lenitive, with less violence. However, they were ineffective when matter remained lodged high in the stomach. Bleeding lowered heat and volume swiftly, but excessive or poorly timed phlebotomy could induce coldness, pallor, and collapse. Thus, physicians matched the route to the dominant sign cluster, then scaled intensity to the patient's strength. Aftercare tied the routes back into regimen. Following emesis, text recommended warm broths, barley waters, gentle aromatics, ginger, cinnamon, in small doses, and rest. No raw fruit or cold drinks that might rekindle crudities. After laxatives, hydration and light potages restored moisture without burdening digestion. After bleeding, cooling but nourishing drinks and avoidance of exertion were standard. In each case, the evacuation was an intervention within a longer program, not a standalone cure. The physician's goal was to re-establish orderly coction and circulation so that the next meals would build healthy blood rather than new imbalance. Working within that regimen-first approach, medieval physicians looked for concrete clusters of symptoms that indicated when evacuation, especially upward evacuation, was warranted. The guiding question was simple: is there recent, obstructive, and corruptible matter in the stomach that the body is failing to process? If yes, emesis was considered a rational targeted response. If no, they preferred other routes or deferred evacuation entirely. The most common trigger was persistent nausea accompanied by sour or fetid eructations. Dietetic texts framed these as signs of crudities, the failure of coction in the stomach. A heavily coated tongue, unpleasant morning breath, despite recent tooth powders, and a sense of pressure beneath the breastbone were all read together as evidence that food had not been properly cooked into nutriment. Practitioners palpated the epigastrium and asked practical questions: what was eaten, in what sequence, how late, and with what drink. Meals described as heavy in fats, cold in quality, or mixed from many incompatible dishes, fish, fruit, dairy, multiple meats, raised suspicion that the stomach's heat had been overmatched. Headache and head heaviness were also classic indications, especially when temporally linked to large meals. The explanatory model held that vapours from poorly processed food rose from the stomach to the head, disturbing the senses and sleep. A patient who reported frontal headache, dizziness, and mental fog after feasting, improved transiently by belching and worsened by lying flat, was a typical candidate for upward evacuation. Importantly, timing mattered. Symptoms appearing within hours of a banquet or on the following morning suggested offending matter remained in the upper tract. Days-old symptoms without a feast history pushed physicians toward downward purgatives or non-evacuative regimen. Observation extended to excreta. While uroscopy was used most commonly to judge fevers and general coction, some authors noted pale, thin, or excessively cloudy urine after indulgence as circumstantial support for incomplete digestion. Constipation with lower abdominal discomfort argued for a downward approach instead, but soft, scant stools with upper fullness fit the emesis profile. If the patient had already vomited spontaneously, physicians inspected the material. A strongly bitter taste and yellow-green colour suggested bilious excess. Large volumes of partially digested food confirmed the diagnosis of crudities. In both cases, a controlled purge was thought to finish what the body had begun and prevent further corruption. After-feast complaints were a recurring clinical setting. Courtly and urban banquets supplied the paradigm. Rich meats, thick sauces, pies and spiced wines consumed late and in quantity. Dietetic rules warned against rapid alternation of hot and cold dishes, raw fruit taken at the wrong point in the meal, or drinking heavily while food remained raw in the stomach. When a patient presented after such occasions with upper abdominal heaviness, queasiness, restless sleep, and a waking headache, many regimens recommended a morning emetic rather than waiting for the mass to descend. The aim was to remove the undigested load before it mixed into the blood and seeded longer disturbances. Physicians also weighed complexion and pulse. A warm, moist, ruddy patient with strong pulses could tolerate a brief, induced purge better than a pale, dry, elderly or exhausted patient, in whom vomiting might do more harm than good. Dry mouth, extreme thirst and weakness were cautions. They implied dehydration or depletion, conditions that emesis would worsen. Active high fevers with a tense, bounding pulse and signs of inflammation directed practice toward bleeding first, if evacuation was needed at all. Only after heat abated would they reconsider purging. Because signs could overlap, manuals emphasized proportion and sequencing. If the picture suggested mild crudities, modest nausea, slight heaviness, physicians often started with corrective regimen: early rising, gentle walking, warm spiced drinks, small doses of ginger or cinnamon, and simple broths to encourage coction. Should these fail, they escalated to mild emetics such as warm salted water or feather stimulation. Potent pharmacological emetics, e.g. hellebore, squill, were reserved for robust patients with clear indications and under supervision, precisely because the dose-response curve was narrow and adverse effects real. Special populations sharpened the diagnostic threshold. In children, the elderly and pregnant women, the same signs did not automatically authorize emesis. Physicians leaned toward lenitive downward remedies or non-evacuative measures, unless symptoms were severe and clearly gastric. Similarly, in winter, when bodies were judged colder and drier, many authorities preferred to correct with warming foods and thyme rather than induce vomiting, which was seen as drying and weakening. Finally, documentation mattered. Learned practice prized a brief case history, the exact menu of the feast, the sequence of dishes, the interval between eating and lying down, and prior tendencies towards similar episodes. Recurrent patterns, always sick after late meat pies and heavy wine, supported the interpretation of upper crudities and justified an immediate targeted purge followed by stricter dietetic rules. One-off events with mixed signs encouraged caution and watchful regimen first. In sum, the decision to vomit rested on a reproducible set of indicators: nausea with sour belching, epigastric fullness, post-feast headaches, coated tongue, and evidence of undigested matter, considered against constitution, season, and risks. Only when the balance of signs pointed clearly to the stomach did medieval physicians choose the upward route. Those bedside heuristics were not improvised. They descended from the classical medical canon. In the Hippocratic corpus, disease was framed as disturbance in mixture and movement of humours, and therapy aimed to assist nature by removing what was excessive or out of place. Within that programme, vomiting had a defined, though limited, role. Case histories and aphorisms describe physicians provoking emesis when recent food stagnated in the stomach, when bilious symptoms dominated, bitter taste, burning epigastrium, or when nausea and head heaviness followed a heavy meal. The reasoning matched the diagnostic cluster medieval doctors later repeated. If the stomach's cooking, pepsis, failed, the safest correction was to expel material before it spread through the blood. Hippocratic writers tethered emesis to timing and strength. They distinguish between aiding nature's own effort, a patient already nauseated after overindulgence, and forcing the body against resistance. They favoured gentle methods first, warm drinks taken in quantity to trigger regurgitation, before resorting to pharmacological emetics. They also linked indications to season and constitution. Cold, damp bodies and colder seasons were considered less tolerant of strong purges upward. Robust, warm patients could endure them when the signs clearly pointed to recent gastric burden. Crucially, Hippocratic texts warned that evacuation should follow signs of ripening, coction, in fevers. Removing unripe humours risked worsening the illness. When the problem was postprandial crudities rather than systemic fever, the stomach counted as a special case. There the goal was to empty recent, unassimilated matter promptly and then restore orderly regimen. The Hippocratic approach also contrasted routes. Vomiting addressed disorders localized to the upper tract. Downward purgatives treated burdens seated in the intestines. Bloodletting addressed excess heat and volume in the vascular system. Physicians chose among these based on clusters of signs rather than single symptoms. Bad taste and sour belching with epigastric weight argued for emesis. Lower cramping and retained stools argued against it. This comparative reasoning, not enthusiasm for any one technique, is what medieval handbooks later adopted. Galen systematized and expanded this inheritance. He retained the humoral framework and the staged model of digestion, first in the stomach, then in the liver, then through the vessels, and made the stomach's role central in both diagnosis and treatment. In his therapeutic writings, often summarized in Latin as methodus medendi, Galen set out a logic of indications. If there is a peccant matter in a particular place and the patient's strength permits, remove it by the nearest and least harmful route. Upward evacuation therefore had a clear indication: undigested food or acrid bile retained in the stomach. But Galen insisted on preparation, preparasci, and measure. He typically called for a period of softening and thinning humours with suitable diet and drinks, e.g. tepid hydromel, before any strong purge. When the case was acute and obviously gastric, like a recent surfeit, this preparation could be brief. Galen distinguished between agents and their powers. White hellebore, a violent emetic, and squill were placed at the drastic end and were to be used only with careful dosing and after weighing risks. Mechanical aids, tickling the falces with a feather, warm salted water in quantity, stood on the milder end and could be supervised at home. He associated emesis particularly with excess yellow bile, hot, dry, irritating the stomach, but he also described cases where phlegm, cold, wet, pooled in the upper tract. In the latter, he preferred first to warm and attenuate the phlegm, and more often sent it downward with lenitives. Black bile, in his view, was stubborn and better addressed by repeated gentle purgation and long-term regimen rather than by vomiting, which he regarded as too exhausting for melancholic constitutions. Sequencing and contraindications were explicit. Galen warned against provoking emesis in active inflammations of the throat or chest, in extreme weakness during late pregnancy or where dehydration was evident. In hot, full conditions, he often bled first to reduce dangerous heat and tension, then considered evacuation of the gut if signs persisted. After emesis, he prescribed specific aftercare, rest, warm broth, small amounts of aromatic spices to prevent relapse into crudities. The point, as with Hippocrates, was not evacuation for its own sake, but restoring orderly coction so that subsequent meals would be converted into healthy blood. Galen also addressed the social reality of treatment. Because potent emetics were hazardous without precise compounding, he located their preparation in the apothecary's art and their indication in the physician's judgment. At the same time, he acknowledged that households would attempt simple measures after obvious overindulgence. His texts therefore include practical guidance for non-specialists on what to attempt, tepid drinks, early timing, and what to avoid, cold water, overeating immediately after. These details travelled well into medieval practice through summaries and epitins. In short, the classical authorities established the decision tree. Medieval physicians followed. Identify the place and quality of the offending matter. Choose the route that removes it with minimal harm. Scale the strength to the patient and embed the act within regimen before and after. Vomiting, in this framework, was a targeted tool, appropriate when signs pointed to the stomach and recent crudities or bile, rather than a blanket remedy. The medieval textbooks that students copied and glossed would soon transmit this logic alongside new commentaries and Arabic syntheses, but the foundation remained Hippocratic and Galenic. Building on that classical framework, medieval physicians encountered vomiting as a clearly delimited tool in two influential streams of learning, Avicenna's canon of medicine and the Salernitan regimen literature. Through Latin translations from the 12th century onward, especially Gerard of Cremona's, the canon became a standard university text. It organised therapy under a general logic of indications, preparation, act and aftercare. Within that structure, emesis appears as one route of evacuation, justified only when signs show peccant matter retained in the stomach or acrid bile irritating the upper tract. The message students absorbed was not vomit often, but vomit when the problem is gastric and recent. Avicenna defined the target condition with precision. He ties emesis to failures of primary digestion, crudities, heaviness after eating, sour eructations, headache linked to recent surfeit, and to bilious disturbances felt in the epigastrium. He repeatedly insists on proximity, remove by the nearest route what is located in the part. Thus, emesis addresses matter in the stomach. Catharsis, downward purgatives, addresses burdens seated in the intestines. Phlebotomy addresses dangerous plenitude and heat in the vascular system. If signs are mixed or point lower, he prefers lenitive laxatives or clysisters. If heat and tension are dominant, he bleeds first and reassesses. Preparation is central in the canon. Avicenna urges physicians to ripen, soften and attenuate thick, cold humours before attempting any strong evacuation. For gastric crudities after a feast, that preparation may be brief. Tepid hydromel, honey water with a mild acid, gentle walking, early rising, because the material is recent. For chronic conditions, he delays purging until the body shows signs of coction. He also scales intervention to temperament, age and season. Warm and moist temperaments tolerate emesis better than cold and dry. The elderly and very young are poor candidates for strong emetics. Winter, cold-dry, is an unfavourable time for upward drying measures. Early morning on an empty stomach is the safer moment. These rules transpose the Hippocratic cautions into a systematic checklist. On agents, the canon distinguishes simple from compound emetics and ranks their powers. Mild methods, large draughts of tepid, lightly salted water, throat stimulation with a feather, are acceptable in household practice for obvious surfeit. Pharmacological emetics, e.g. white hellebore, squill, demand medical supervision because dose response is steep and adverse effects real. Avicenna recommends tempering drastic drugs with honeyed water or mucilaginous vehicles to moderate violence, and he is explicit about contraindications, active inflammations of throat or chest, marked weakness, pregnancy, dehydration, and recent bleeding. Aftercare follows immediately. Rest, warm broths, small quantities of aromatic digestives, ginger, cinnamon if appropriate, and avoidance of cold drinks or raw fruit that could reintroduce crudities. The Salernitan corpus, both didactic verse, Regimen Sanitatis Salernitanum, and prose handbooks associated with the Schola Medica Salernitana, transmitted the same therapeutic priorities in a practical register. The regimen is primarily dietetic. It tells lay readers how to avoid needing evacuation at all. Moderation in quantity, correct ordering of dishes, no heavy meats late at night, fruit at the proper point in the meal. When it touches evacuation, the tone is cautious and conditional. Purge in season, in the morning and only with signs. Prefer mild means first, strengthen the patient after. Its function in the clinical ecosystem was preventive, reduce the occasions for crudities that would force a purge. Other Salernitan works gave physicians and apothecaries operational detail. The Antidotarium Nicolai lists compound preparations, including agents relevant to emesis and catharsis, with ingredients, measures and pharmaceutical forms. Its widespread authority helped standardize compounding and dosing across Latin Europe. Plierius's Practica Brevis and related practical handbooks summarize when to choose upward versus downward evacuation for common presentations, post-feast headache and epigastric weight versus lower colic and retained stools, echoing the decision tree seen in Galen and Avicenna. The Salernitan women's medicine texts, the Trula ensemble, add population-specific cautions. avoid violent purges and emetics in pregnancy and early puerperium, prefer gentle correctives and regimen unless indications are compelling. Together, these texts anchor therapeutic choice in patient category as well as symptom pattern. Institutionally, Salerno served as a bridge. Its manuals circulated among lay elites and practitioners, shaping expectations about timing, in the morning after adequate sleep, sequence, prepare, evacuate, restore, and scale, start mild, escalate only as needed. University teaching then folded Avicenna's more elaborate logic into this regimen culture. Commentaries and glosses instructed students to collect a short case history keyed to the canon's indications: meal content and order, interval since eating, character of eructations, quality of sleep, stool pattern, complexion, pulse. From that dataset, the student was to decide emesis now, a lenitive purge later, a phlebotomy first, or regimen alone. The net result for medieval practice was convergence. Avicenna supplied a systematic framework for when and how to induce vomiting. Salerno equipped physicians and households to prevent the need and, when necessary, to carry it out with measured techniques and standard compounds. Both streams emphasized that vomiting was a targeted response to a defined gastric problem, embedded in preparation and aftercare, and limited by contraindications. That shared, rule-based approach is what appears in the university concilia and bedside notes of the 13th and 14th centuries, and it set the stage for how later scholastic medicine would debate and refine evacuation under the heading of university medicine. Within the medical faculties at Bologna, Montpellier, Paris, and Oxford, this Galenic Avicennian framework was turned into a teachable, repeatable system. University medicine relied on a stable canon of texts, fixed classroom procedures, and written genres that translated theory into bedside rules. Students encountered vomiting not as an ad hoc household trick, but as one option in a structured decision tree, with indications, contraindications, preparation, act, and aftercare spelled out in predictable places across the curriculum. Teaching centred on the lectio, the master read an authoritative text, commonly items from the Articella compilation, Hippocrates' aphorisms and prognostics, Galen's Tegni Ars Parva, Theophilus on urines and pulses, and increasingly from the 12th century onward, Avicenna's canon. He glossed line by line, drawing out practical indications, signs that authorise an intervention, and impediments, reasons to defer. In this setting, emesis was positioned as the upper evacuation, chosen when signs showed recent gastric burden or acrid bile in the stomach, nausea with sour eructations, epigastric heaviness after surfeit, frontal headache linked temporally to feasting, while laxatives, clysters, or phlebotomy were matched to different sites and qualities of disease. Students copied these distinctions into personal notebooks, producing a de facto standardized checklist. Beyond the lectio came the quaestio and disputatio, exercises that forced students to weigh alternatives. Typical problems asked whether to bleed first in hot, full conditions or whether to purge upward immediately after a banquet, whether phlegmatic crudities should be thinned before any purge, or how age, sex, temperament and season altered the choice of route. Instructors like Taddeo Alderotti at Bologna or Gentile da Foligno at Perugia used Avicenna's chapters on evacuation to anchor these debates. The result was less dogma than routinized reasoning. Identify place and quality of peccant matter. Prefer the nearest route that does least harm. Scale the strength to the patient. Commentary literature fixed these choices in writing. Marginal and interlinear glosses on the canon and Tegni distilled decision rules into portable formulas. If crudities are recent and seated in the stomach, use mild emesis in the morning on an empty stomach. If signs are lower, prefer lenitive catharsis. If heat and tension dominate, bleed first, then reassess. Model schedules specified timing, spring and autumn clean-outs for prevention, early morning for safety, and cautioned against emesis in winter dryness, late pregnancy, marked weakness, or active throat chest inflammations. Because the same cautions appear across numerous commentaries and student notebooks, we can see how lecture hall consensus became standardized advice. Parallel practical textbooks reinforced this convergence. Gilbertus Anglicus's Compendium Medicinae, Bernard de Gordon's Lilium Medicinae, Montpellier, and John of Gaddesden's Rosa Anglica reorganized the canon into symptom-based chapters. Each treated post-feast headache, sour belching, and epigastric weight as a recognisable cluster and recommended a graded response. Regimen first, early rising, gentle walking, tepid hydromel, then mild emesis, warm salted water, feather stimulation, reserving drastic emetics, hellebore, squill for robust patients under supervision. They also placed emesis among alternatives, downward purges for intestinal burdens, phlebotomy for hot plethora, sudorifics and baths in specific fevers, and provided aftercare, light broths, warming aromatics, avoidance of cold raw foods, to close the loop. Standardization extended to pharmacy. University syllabi pointed students to widely accepted formularies such as the antidotarium Nicolai for compound preparations with agreed measures and vehicles meant to moderate violent drugs. This gave physicians a common language for prescribing and apothecaries a common basis for compounding. Urban statutes and guild regulations, where they existed, further encouraged uniform practice by requiring approved texts and recipes in apothecary shops, which indirectly constrained how and when potent emetics were dispensed. Astrology and calendars also entered the classroom as tools of timing. Bloodletting tables linked days and zodiacal signs to safer moments for venesection. Similar, if more cautious, advice circulated for purging. Avoid the very driest heat of high summer for strong evacuations. Prefer the waxing portion of the month for certain regimens. Never purge on days when the patient is already depleted. Whatever we think of the premises, their practical effect was to slow the decision and embed it in routine checks rather than impulse. Finally, the consilia genre, written consultations for specific cases, functioned as capstones. Masters recorded brief case histories, listed signs, weighed routes, and justified a chosen sequence. Bleed lightly today to temper heat. Tomorrow administer a lenitive clister. If upper crudities persist, provoke a mild emesis at first light. Thereafter, regimen with simple, warm foods. Collections of consilia circulated among practitioners and students, providing worked examples that echoed classroom rules while showing how to scale decisions to constitution, age and season. Because these documents repeat the same clusters of indications and the same guardrails, they reveal how university teaching produced a shared therapeutic vocabulary. In short, university medicine did not increase enthusiasm for vomiting. It narrowed and regularized its use. Through lectures, commentaries, handbooks, formularies, calendars and consilia, the faculties taught physicians to recognize the upper gastric cluster that justified emesis, to prefer milder means first, to avoid known dangers, and to embed the act in preparation and aftercare. That standardization explains why similar advice appears from Paris to Montpellier in the 13th and 14th centuries, and why later critics could argue against purging culture by addressing a recognizable codified practice rather than scattered custom. Within that standardized university practice, the how of provoking emesis focused first on plant drugs whose powers were well known to physicians and apothecaries, above all white hellebore and squill, supported by milder sharp vehicles such as oxymel, honey vinegar, and salted or wine-based infusions. Texts placed these agents on a spectrum from drastic to gentle, and insisted that their use be limited to clear gastric indications, scaled by constitution, and buffered by careful compounding. White hellebore, veratrum occupied the top end of the emetic scale. Classical and medieval writers classed it as a violent, evacuative upward drug with significant risk if mismeasured. University commentaries therefore tied it to robust patients and acute, unmistakable cases of recent surfeit or acrid bilious irritation in the stomach. Apothecaries prepared hellebore from the dried root, powdered finely and commonly incorporated into pills or troches to control portion size. Physicians tempered its harshness by mixing tiny amounts with mucilaginous or sweet vehicles, barley water, honeyed water, almond emulsion, and by pairing it with digestive aromatics, small additions of ginger, anise or fennel, thought to protect the stomach and help expel vapours. Dosing was expressed in the usual apothecary weights, grains, scruples, and handbooks warned against repeating a dose if the first had already produced sufficient evacuation. Contraindications, marked weakness, pregnancy, chest inflammation, winter dryness, were standard, and the expectation was that hellebore would be administered under a physician's direction rather than attempted as a household remedy. Squill, Scilla drimia maritima, sea onion, was framed as somewhat less violent and more versatile. In lower doses and syrup forms, it acted as an expectorant. In larger doses or in specific preparations, it became emetic. The widely circulated formularies listed oxymel of squill, oxymel soliticum, vinegar and honey boiled with squill to an agreed consistency, then strained. Physicians valued this preparation because the honey-vinegar vehicle both attenuated thick humours and offered a controllable medium. Patients could take it by spoonfuls, and the dose could be adjusted to induce mild nausea or a full purge. As with hellebore, practice required attention to temperament and season. A warm, moist adult in spring after a feast tolerated squill better than a dry, elderly patient in winter. Because squill was pungent, texts advised following it with tepid water to assist the impulse, and then discontinuing once the aim was met. Alongside these two, manuals referenced sharp infusions designed to nudge a stomach already on the verge of vomiting rather than to force the issue pharmacologically. The simplest were large draughts of tepid salted water or tepid water acidulated with vinegar or oxymel. The logic was mechanical and qualitative. Warmth and liquidity relaxed the stomach and diluted the offending mass. Light salting or vinegar added a stimulating sharpness that encouraged regurgitation without the hazards of drastic simples. These were the measures most often permitted in household use for the archetypal scenario, an otherwise healthy adult experiencing heaviness, sour eructations, and frontal ache the morning after a heavy banquet. If such measures failed, techs moved the case back under professional supervision before stronger agents were tried. Compounding practices reflected the same caution. Apothecaries relied on recognised authorities, e.g. standard antidotaries for proportions and forms, troches of squill for storability and dose control, syrups for graduated administration, powders incorporated into electuaries for dispersal in protective vehicles. Many recipes included adjuvants and correctives, aromatics, ginger, cinnamon, in very small amounts to open obstructions, demulcents, barley, quince to soften the stomach's lining, sometimes a drop of oil to ease passage. Physicians also specified preparation before the act, a short period of light, warm drinks, hydromel, early rising and gentle walking to promote coction and mobilise the load, followed by the emetic on an empty stomach, typically early morning. Choice among these options tracked the diagnostic cluster. If the signs pointed to recent gastric crudities without systemic heat, a sharp infusion or oxymel might suffice. If the picture suggested acrid yellow bile irritating the stomach, bitter taste, burning epigastrium, squill or, in robust patients, white hellebore could be prescribed, still with buffers and tight dose control. If the patient's constitution was cold and dry or the season winter, many physicians deferred emetics entirely, preferring to warm and attenuate with regimen and, if needed, send matter downward with lenitives. The point repeated across commentaries is that route and potency followed signs and context, not patient preference or habit. Risk management was explicit. Writers catalogued adverse effects, excessive dryness, syncope, throat irritation, and set stop rules. Discontinue once sufficient evacuation and subjective lightness of head, easing of pressure were achieved. Do not repeat immediately. Institute aftercare, rest, warm broths, small sips of diluted wine or spiced waters to restore moisture and stabilise digestion. They also addressed misuse. Emetics were not to be taken prophylactically before feasts, nor used to license gluttony. In moral and medical terms, that crossed the line from therapy to vice and practically increased the risk of depletion and long-term digestive weakness. Finally, accessibility shaped practice. Hellebore and squill required a functioning supply chain, gardens, import routes, and a trained apothecary to prepare safe forms. Salted or acidulated warm water required only household ingredients. University medicine accommodated that reality by reserving the drastic plants for supervised cases and teaching lay audiences, via Salonitan regimen poems and vernacular guides, when and how to attempt the mildest measures. In every instance, the herbal emetic sat inside a three-part sequence: brief preparation to ripen and mobilise, a carefully chosen and measured act, and aftercare to re-establish orderly coction and prevent relapse. Following the preference for mild, controllable measures, university and regimen texts placed mechanical methods at the bottom rung of the emetic ladder, used first in clear recent gastric overload, and abandoned quickly if ineffective. These methods relied on simple physiology: distend the stomach with warm fluid, stimulate the falces to trigger the gag reflex, and assist an expulsion that the body is already attempting. Because they required only household tools, they appear frequently in practical handbooks aimed at lay readers and in the after-feast scenarios physicians described. The most cited technique was tickling the falces with a feather. Guides specify a clean, soft feather, often goose, moistened so that barbs would not scratch the mucosa. Some authors recommend dipping the tip in tepid water, oxymel, or a little oil to reduce irritation and to avoid losing loose barbs in the throat. The patient was seated upright, leaning forward over a basin with the tongue depressed gently by the non-dominant hand or a wrapped spoon handle. The feather was passed to the back of the mouth until it touched the falces. Brief contact was usually sufficient to provoke the reflex. If nothing happened immediately, the instruction was to withdraw, allow a few breaths, and try once more rather than persistently scraping. Manuals warn against use in active throat or chest inflammation, recent nosebleed, late pregnancy, extreme weakness, or with intoxicated patients who could not follow directions, contexts where gagging risked harm. A companion measure was large draughts of warm, lightly salted water, or water sharpened with a little vinegar or oxymel. The fluid served two purposes. It warmed and thinned the stomach's contents and provided volume to facilitate expulsion once the reflex was triggered. Texts emphasized tepid rather than hot or cold. Heat was thought to relax and soften, while cold was blamed for fixing crudities. Salt or vinegar added a sharpness believed to rouse a sluggish stomach without the violence of pharmacological emetics. The patient drank steadily until a sense of fullness or queasiness arose, then either vomited spontaneously or used the feather once or twice to complete the act. If no response followed, the advice was to stop rather than continue drinking to discomfort. Repetition on the same day was discouraged unless instructed by a physician. Under the same heading fall other induced gag maneuvers meant for strictly bounded use: touching the root of the tongue with a wrapped finger or smooth instrument, brief nose pinching while the mouth contained tepid water to nudge a cough gag, or asking the patient to perform a few gentle abdominal strains while leaning forward. All were presented as adjuncts to an already developing emetic effort, not as standalone procedures to force a hostile body to comply. Authors repeatedly stress posture and supervision: seated, head and torso forward, never supine, a basin ready, a second person present to steady the patient, and to stop the attempt at the first sign of distress or lightheadedness. Standard preparation and timing applied. Mechanical measures were recommended early in the morning on an empty stomach, after a short preparatory period of tepid drinks and gentle walking to mobilize the load. The sign profile was the familiar one: nausea, sour eructations, frontal headache, epigastric weight within hours of a heavy mixed meal. If lower gut signs predominated, retained stools, lower cramping, texts redirected the case to lenitive clysters or laxatives rather than any upward method. Seasonal cautions also carried over. In winter, with its cold and dry qualities, practitioners preferred to correct with warming regimen and defer gagging unless indications were compelling. Stop rules and aftercare were explicit. The goal was to evacuate recent undigested material and any acrid fluid irritating the stomach. Once the vomitus ran mostly clear or watery and the subjective pressure eased, the attempt ceased. Prolonged retching was classed as harmful, drying and weakening. Afterward, patients rinsed the mouth with tepid water or diluted wine, rested, and took small quantities of warm broths. Cold drinks, raw fruit and heavy meats were prescribed for the day. If headache or chest soreness lingered, small sips of spiced waters were permitted, but additional gagging the same day was discouraged. Because these methods were accessible, writers also addressed misuse and risks. They condemn employing gagging prophylactically before or during feasts, or as a license to overeat, an overlap of medical imprudence and moral criticism. Practical cautions include avoiding rough or stiff feathers, not inserting instruments deeply, stopping immediately for throat pain, bleeding, or dizziness, and never performing the maneuver on an uncooperative or drowsy person. Choking risk is managed by forward posture and alert supervision. In children, the elderly and pregnant women, Manuals advise against induced gagging altogether or insist it be undertaken only with a physician's counsel. In clinical sequencing, mechanical methods formed the first rung. Try tepid salted water and forces stimulation once in a clear after-feast case. If effective, stop and proceed to regimen. If ineffective, do not escalate at home to drastic drugs. Physicians reserved herbal emetics, such as squill or hellebore, for robust patients and for cases they judged unmistakably gastric. With supervision and dose control, downward remedies or simple regimen were chosen when signs were mixed or pointed lower. Finally, these techniques illustrate the standardization that university medicine sought. Even simple household acts were folded into the same structure as pharmacological therapy. Indication, recent gastric crudities; preparation, tepid drinks, early timing; measured act, brief feather stimulation, limited warm saline draughts; termination criteria, and aftercare. The consistency of this advice across commentaries, handbooks, and vernacular regimens indicates that mechanical tricks were not improvisations but codified steps in a conservative strategy. Evacuate only when signs and context align, by the least violent means first, and return immediately to the diet and routine that prevent recurrence. These standardized steps also sat within a clear division of labour. In university towns and larger cities, the physician decided whether evacuation was warranted, chose the route, upward, downward, or bloodletting, and specified strength, timing, and aftercare. He worked from a fixed repertoire of indications: recent gastric crudities, bilious irritation of the stomach or post-feast headache, and wrote the order in Latin, often listing the vehicle: oxymel, barley water, the simple or compound drug, e.g. squill syrup, hellebore, troches, dose and instructions, main, jejunus, early morning fasting. The same physician might also set stop rules in the recipe: discontinue after 2 effective efforts, no repetition the same day, proceed to broths and rest. Because potent emetics had narrow safety margins, the expectation in learned medicine was that a physician supervised their use, returned to observe the effect, and adjusted regimen afterward. The apothecary translated that written decision into a safe, measurable preparation. Training came by apprenticeship and guild regulation rather than the university. In practice, apothecaries relied on recognised formularies, above all widely copied antidotaries, for standard compositions and weights. The shop's work was technical, sourcing verified simples, squill bulbs, hellebore root, drying and powdering, making troches for dose control, boiling oxymel to the prescribed consistency, and straining syrups. Quality control meant calibrated balances, agreed measures, and storage in clean-labelled jars. Municipal ordinances in many cities required standard weights and periodic inspection. Some also restricted the sale of drastic substances unless prescribed. Apothecary account books suggest how the chain functioned: a physician's written prescriptio, a compound dispensed in a form the household could administer, and sometimes a note on when to return for observation or renewal. At the bedside, barber surgeons and infirmarians often handled other routes of evacuation: venesection, clysters, and baths, leaving upward purgation to the physician-apothecary pair. Barber surgeons were licensed through their own guilds and trained in manual procedures. Hospital and monastic infirmaries, where they existed, blurred the lines. Infirmarians tended herb gardens, compounded simple syrups, followed bloodletting calendars, and implemented physician instructions for patients under their care. Even there, the decision to use drastic emetics was treated as medical, not purely practical. Most households only improvised at the mild end of the spectrum. Vernacular regimen guides and moral dietetic poems, circulating in Latin and local languages, taught lay readers to avoid feasting errors and, when they erred, to try limited measures. Early rising, gentle walking, tepid drinks, and, if necessary, a small quantity of warm salted water with brief forcey stimulation using a feather. These were framed as first aid for a recent, self-evident overload in an otherwise healthy adult. Escalation to pharmacological emetics was discouraged without professional oversight. The reasoning was practical. The mild methods were reversible and predictable. Hellebore and strong squill preparations were not. Urban-rural differences mattered. In towns, access to physicians and apothecaries made the formal chain workable. Households still acted first, but escalation pathways were near at hand. In villages, people relied more on local healers and household knowledge. Digestives: mint, fennel, anise, warm drinks, light broths, and rest. Garden hellebores existed in northern Europe, but confusion among species and the recognised danger made unsupervised use risky. Prescriptive texts repeatedly warn against violent upward drugs outside medical direction. Where apothecaries were scarce, physicians sometimes wrote consilia by letter to patrons. A brief history, indication, a recommended sequence, regimen, mild emesis, diet, and a recipe the patron could take to a distant or travelling compounder. These documents show the same guardrails: dose limits, contraindications, and aftercare, even when care was semi-remote. Gender and status shaped who acted. In elite households, stewards and matrons managed regimen and first-line measures. Recipe collections kept in gentry homes included instructions for oxymel, barley waters, and simple digestives, alongside cautions about stronger substances. Women as household managers oversaw preparation of broths and post-emesis care. In pregnancy and puerperium, the same collections either forbid emetics or instruct consultation with a physician, reflecting the long-standing caution in women's medicine texts. Among the poor, remedies tended to remain at the level of regimen and mild mechanical aids. Cost and access limited recourse to compounded drugs. Payment structures reinforced separation of roles. Physicians charged for advice, visits, written consilia, periodic oversight. Apothecaries charged for materials and labour. Many municipal statutes discouraged physicians from operating apothecary shops, attempting to keep diagnosis and dispensing distinct. The aim was both quality control and prevention of profit-driven overprescribing. Whatever the statute's effectiveness in practice, the ideal division left judgment with the physician and manufacture with the apothecary, while households executed the plan and observed results. Record-keeping anchored accountability, and physicians kept case notes or copies of consilia. Apothecaries maintained day books listing compounds dispensed, quantities and recipients. Hospitals recorded regimens followed and outcomes. Because the same phrases recur: in the morning, fasting; after adequate rest; avoid cold drinks and raw fruit that day, we can see how standardized advice filtered from lecture hall to shop and household. Even simple acts like feather stimulation appear with the same cautions across sources: seated posture, a basin ready, stop at first sign of distress, do not repeat in the same day. In sum, the practice of inducing vomiting was distributed. Physicians set indications and limits. Apothecaries converted orders into safe, measurable forms. Barber surgeons and infirmarians handled adjacent evacuations. Households applied the mildest steps and provided observation and aftercare. This division of labour did not increase the use of emetics. It bounded and regularised them. When the chain worked as intended, upward evacuation appeared as a brief, targeted intervention inside a larger programme of regimen, exactly the conservative strategy the universities taught. Building on that conservative, regimen-first strategy, timing supplied the other half of the rulebook. Medieval dietetic and university texts routinely advised that evacuations be concentrated in the temperate seasons, spring and autumn, when the body could best tolerate them and when environmental change was believed to stir humours. These were the classic clean-outs in regimen literature, not standing orders to purge everyone, but windows during which, if signs and constitution allowed, physicians might schedule bleeding, mild catharsis, sweating, or, where indications were clearly gastric, a brief emesis. The rationale was humoral. Spring, characterised as warmer and moister, was associated with blood. After the cold, dry winter, heavy foods, reduced exercise, the body was thought to carry residues that had not been fully cooked. As temperature rose, those materials softened and moved, creating a favourable moment for controlled evacuation. Hence, spring instructions often prioritised small phlebotomies for sanguine plethora and lenitive downward purges. Emesis entered only when the symptom cluster pointed to recent crudities in the stomach: nausea, sour eructations, epigastric heaviness, post-feast headache. The guidance stayed consistent: choose the route nearest to the offending matter, then scale intensity to strength and season. Autumn, paired with black bile, cold, dry, marked the second preventive interval. The aim was to prepare the body for winter by reducing accumulations that would otherwise harden and impede coction in the months ahead. Regimens leaned on gentle purgatives and diet correction to thin melancholy and phlegmatic residues. They cautioned against strong, drying measures that might leave patients depleted entering colder weather. As in spring, emesis remained a targeted option, appropriate if unmistakable gastric signs followed recent surfeit, but otherwise unnecessary. Writers repeatedly warned that routine vomiting for maintenance was poor practice. Seasonal timing never overrode the requirement for specific indications. Calendrical advice drilled down to day and hour. Early morning, fasting, after adequate sleep, remained the preferred moment for any purge. This applied equally in spring and autumn. Many regimens discouraged strong evacuations in the extremes. Deep winter, too cold, dry, and peak summer, too hot, dry, on the grounds that they risked excessive dryness and weakness. Practical manuals echoed civic and monastic bloodletting tables. Avoid days of extreme heat and the immediate aftermath of heavy labour. Space evacuations several days apart. And interpose preparation, light, warm drinks, early rising, gentle walking, and aftercare, broths, diluted wines or spiced waters, rest. Institutions operationalised these calendars. Monastic infirmaries coordinated quarterly bloodlettings and seasonal purges, adjusting diet and work obligations accordingly. University-trained physicians advising households or hospitals wrote consilia that explicitly scheduled spring or autumn interventions, often as part of a broader regimen plan for the year. Apothecaries, in turn, stocked syrups and electuaries suited to these windows, oxymel of squill, lenitive electuaries, demulcent broths, anticipating seasonal demand. Municipal ordinances that regulated apothecary shops indirectly reinforced the rhythm, since inspections and approved formularies aligned compounding practices with widely read regimen texts. Risk management accompanied the calendar. Even in the good seasons, authors set thresholds, defer evacuations during active fevers until signs of coction appear, avoid emesis in throat or chest inflammation, be cautious in the elderly, children and pregnant women, and discontinue at the first adequate effect. Spring and autumn were thus safer opportunities, not blanket permissions. Writers also addressed misuse. Seasonal timing was not a license to purge for gluttony. Repeated emesis before or after every feast was condemned as both moral failing and a medical cause of long-term digestive weakness. Household practice reflected these limits. Vernacular regimens popular with lay readers framed seasonal advice in preventive terms: moderate portion sizes, correct ordering of dishes, favouring easily digested foods in transitional weather. If, despite such measures, a spring or autumn feast produced the classic upper gastric signs, households might attempt the mildest step: tepid salted water, brief feather stimulation, once early in the morning. Anything more was deferred to professional oversight. For many families, seasonal purge meant a brief course of simpler fare, mild lenitives, prunes, figs, and increased walking and bathing rather than drugs. The liturgical year sometimes intersected with the medical calendar. Lenten fasting, often coinciding with early spring, already altered diet and routine. Some texts advised postponing deliberate evacuations during periods of strict fasting because of weakness. Conversely, feast seasons with heavier foods around major church festivals produced the very after-feast complaints that might trigger a targeted purge, again within the seasonal guardrails and only when signs were clear. Finally, the seasonal programme reinforced the broader pedagogical message of university medicine. Timing is part of dose. The same intervention could be curative in April and harmful in January. The same patient might tolerate a mild emesis after a spring surfeit, but require only regimen in autumn. By bundling evacuation with calendars, preparation and aftercare, regimen literature kept emetics at the edge of practice, available when the stomach clearly signalled recent overload, but never routine. In effect, spring and autumn clean-outs were less about emptying the body than about choosing the safest moment to correct specific observed imbalances within a year-long plan of diet, sleep, exercise and restraint. Extending timing beyond clock and calendar, many medieval guides added astrological checks. These did not replace clinical indications. For recent gastric crudities, the decision tree still governed, but they acted as filters for choosing a safer day. Handbooks, almanacs, and university commentaries routinely advised physicians to glance at the moon's phase, the zodiacal sign it occupied, and the pattern of critical days from Hippocratic fever doctrine before scheduling any evacuation, including emesis. First, the moon's phase. Because humoral theory linked bodily fluids to periodic rising and falling, many regimen texts recommended aligning evacuations with the moon's waning half, when moisture and fullness were thought to decrease. The practical rule of thumb ran: avoid strong purges at the new and full moon, prefer the waning interval for depleting measures, and use the waxing phase cautiously, reserving it for strengthening regimens rather than evacuations. In the case of vomiting, which was seen as a drying and straining act, writers folded this into existing safety logic. If signs were unmistakably gastric and recent, a morning emesis could proceed. Otherwise, wait for the waning moon rather than add unnecessary risk during the full or new moon. Second, zodiacal position, expressed through the familiar zodiac man, melathesia, which mapped signs to body regions: Aries head, Taurus neck, down to Pisces feet. The most common caution said, do not evacuate against the part the moon currently rules. Bloodletting tables made this principle explicit for cutting. Many practical regimens extended the caution to purging and emesis on the grounds that these also move humours. Thus, if the moon was in Cancer, chest, stomach, some authors advised avoiding upward purges that might aggravate the region. If in Virgo, belly, or Scorpio, lower abdomen, they preferred to defer strong catharsis. The intent was not astrological determinism, but risk modulation. When the heavens offered a neutral day in the coming week, choose that. When urgency was obvious, e.g. heavy, recent surfeit with classic upper gastric signs, proceed with mild measures regardless. Third, critical days, dies criticis from Hippocratic prognosis. University teaching preserved the idea that fevers tend to break or intensify at periodic intervals, often around the 7th, 14th, 21st day of illness, loosely correlated with lunar quarters. Physicians were taught to avoid major evacuations immediately before an expected crisis, on the logic that nature was already moving humours toward resolution. Interfering might weaken the patient or divert the process. For vomiting, which was rarely part of fever management unless a clear, recent dietary cause remained in the stomach, the rule was simple. Do not schedule emesis on the eve of a crisis day. Reassess after the turn, when signs of coction and stabilisation appeared. In dietetic problems, post-feast complaints without fever, the critical day framework mattered less, but the habit of checking the calendar persisted. These cautions appeared in multiple genres: lectures and commentaries on Avicenna and Galen, brief margins noting avoid purging at full new moon, beware moon in the sign of the affected part, and do not evacuate near crisis. Almanacs and bloodletting tables kept in households and monastic infirmaries, icons for lunar quarters and columns marking prohibited days for cutting, often read across to purging. Concilia written case opinions, short lines such as main eunus si luna decrescens sign cancro differ, which operationalised the checks without long justification. Importantly, physicians distinguished between advisory and compulsory astrology. In university settings, many masters labelled these checks as adjunct prudence, worth observing when the case allowed, dispensable when clinical indications were urgent or when waiting would worsen the condition. This is visible in worked examples. After a late banquet producing classic gastric signs, a concilium might say, attempt a mild emesis at first light tomorrow, even if the moon was waxing, with the justification that proximity of the offending matter outweighed calendar niceties. Conversely, in elective preventive spring cleanouts, the same physician would choose a waning moon day to stack safety factors. Texts also list exclusions that override astrology altogether: active throat or chest inflammation, marked weakness, late pregnancy, recent bleeding or dehydration, states in which emesis is unsafe regardless of sign or phase. The inverse holds as well. Favourable lunar conditions do not authorise vomiting in the absence of indications. Writers criticised those who treated the moon as a standing licence to purge. That, they argued, confused timing with cause and led to depletion. For households, astrological material was simplified. Vernacular regimens sometimes printed a lunary, a short table marking good and bad days, next to advice about meal order and early rising. The message remained conservative. Use these tables to pick a morning if you are already planning a physician-advised purge. Do not use them to self-prescribe drastic measures. Where monastic infirmaries coordinated seasonal bloodletting, they tended to fold purgation and any rare emesis into the same schedule, avoiding full new moon and days flagged as risky, mainly for administrative regularity and perceived safety. In practice, then, astrological cautions funneled decisions already grounded in clinical signs and regimen. Early hours, an empty stomach, and post-feast proximity remained the primary operational rules. Lunar phase, zodiacal position, and critical days supplied secondary guardrails. When combined, morning, fasting, waning moon, neutral sign, the same emetic dose carried a better safety profile. When they conflicted, physicians ranked indication and patient condition first and used the sky as a tiebreaker rather than a master. With those timing guardrails in place, physicians still stressed that most post-emesis decisions began at the table itself. Banquets created the conditions that regimen writers called crudities, incompletely cooked food lingering in the stomach, generating vapours and obstructing orderly digestion. Elite and urban feasts concentrated several risk factors at once: late hour, large quantity, complex mixtures, abundant drink, and dishes engineered for richness. So, medical texts repeatedly analysed banquet physiology to explain why patients woke with nausea, head heaviness, and epigastric pressure. The digestive model was consistent from Galen through Avicenna and the Salernitans. The stomach's task was coction, a warming and softening that converted food into a uniform chyle for delivery to the liver, where it was further processed into blood. Anything that quenched the stomach's heat, cold foods or drinks, excess liquid taken with solids, overmatched it, large portions, hard meats, dense pastries, or confused it, rapid alternation of opposites, hot, cold, dry, wet, or incompatible mixtures produced crudities. These residues were blamed for sour eructations, coated tongue, morning fever, disturbed sleep, frontal headache, and the sensation of weight beneath the breastbone. If the mass remained in the upper tract, texts authorised a morning fasting emesis as the nearest least harmful route of removal. Feast menus pushed toward crudity in recognisable ways: heavy meats and thick pies. Beef, pork, venison, and game birds were prized for status and flavour, but classed as hard or dry in quality, requiring strong gastric heat and thorough mastication. Encasing them in pastry or aspic and serving them late increased the load. Dense meat pies, locked in fats and gravies, large bites swallowed hot with little chewing, were a standard path to morning complaints. Rich sauces. Elite kitchens used bread, almond or egg-thickened sauces, e.g. galantine cameline, sharpened with vinegar and spiced with pepper, ginger, cloves and grains of paradise. Physicians treated spices as digestives in small amounts, warming and opening, but warned that when sauces were thick and abundant, the added bulk and acidity could hinder coction if portions were large or sequence was poor. Mixtures and order. Regimen literature criticised rapid alternation of fish and meat, dairy and fruit, and hot broths followed by cold sweets. The ideal order ran from lighter to heavier, with astringents at the end to close the stomach. Raw fruit was contentious. Some guides placed certain fruits at the start to open, others forbade raw fruit entirely at night. What they agreed on was that wrongly placed fruit, especially after meat and wine, was a reliable crudity maker. Late hour and posture. Feasts commonly ended near or after nightfall. Going to bed soon after a large, complex meal meant the stomach worked while the body lay horizontal. Writers linked this to vapours rising to the head, explaining headaches and restless sleep. Advice to walk briefly after supper before lying down appears in both household and academic sources. Drinking with food, wine and ale were integral to banquets, and spiced wines, hypocras, often closed the meal. Physicians permitted modest drink, but urged little liquid during mastication. More between courses or after coction was underway. Excess drink with solids was said to extinguish the stomach's fire, dilute the chyle and slow transit. Cold water in particular was singled out as a cause of sudden gastric chill and resulting stasis. Salted and smoked items. Prestigious spreads included highly salted fish or meats. These increased thirst and drove drinking. They also added a drying quality that, in the medical model, demanded compensating moisture and careful timing. Taken late, they contributed to the cycle of dryness, extra drink and incomplete coction. Chewing speed and portion size were not ignored. Practical regimens asked diners to chew thoroughly, avoid speaking while eating to reduce air swallowing and belching, and space bites to give the stomach time to grip the incoming food. Rapid courses, especially at court, where service tempo could be brisk, were criticised for forcing the stomach to handle new arrivals before earlier dishes had begun to soften. Physicians connected these banquet features directly to indications for emesis. The typical case history in a concilium notes: evening feast with meats and pies, abundant sauces, much wine, immediate heaviness on lying down, sour reflux in the night, morning headache and foul eructations, soft, scant stool, epigastric weight. In that situation, morning fasting, a mild mechanical attempt with tepid salted water and brief feather stimulation was recommended. If ineffective and the patient robust, a measured squill syrup could follow. If the same diner reported lower cramping and retained stools instead, the physician shifted to lenitive downward measures and diet correction, not vomiting. Importantly, banquet physiology also structured prevention. Household guides urged smaller portions late in the day, lighter broths and easily digested meats in winter when bodies were colder and drier, limited sauces, careful dish order, and a short walk after supper. Spiced wine at the end was permitted in small quantities as a sealer, not as a license to overconsume. Where feasts were unavoidable, manuals suggested next-day regimen: early rising, gentle movement, warm diluted wines or hydromel, simple broths, and only then considering emesis if upper gastric signs persisted. Thus, the medical reading of the banquet was straightforward: rich meats, thick sauces, rapid alternation, much drink, and late hours together created the precise stomach conditions, recent, obstructive, corruptible matter for which a time-boxed morning emesis could be justified. Absent that cluster, physicians preferred to correct by diet and routine, keeping upward purging as an exception rather than a habit. Against that background, courtesy books and household ordinances aimed to prevent the very gastric situations physicians later had to treat. Late medieval books of manners, English, French, German, repeatedly stress moderation, pacing and decorum at table. Take small portions, chew thoroughly, avoid mixing incompatible dishes, do not drink heavily with mouthfuls of food, and do not lie down immediately after supper. Stewards and servers were instructed to regulate service so that courses did not follow one another so rapidly that diners were forced to eat before earlier dishes had settled. Hand washing at the ewer and basin before and after the meal, clean trenchers and orderly clearing voiding the table were part of the same programme of control. The void after dinner, wafers or comfits with a small cup of spiced wine, hypocras, was justified not only as a mark of status, but as a digestive intended to close the stomach and freshen the breath. Etiquette also addressed the obvious hazards. Manuals tell diners not to gorge, not to drink to the point of dizziness, and not to foul the table or floor. Guild and confraternity feast rules similarly set fines for disorderly conduct tied to excess drink. Monastic refectory customs, silence, assigned portions, a short walk after meals when permitted, had the same preventive logic. None of this was primarily medical in form, but the consequences aligned with regimen advice: smaller late portions, fewer abrupt alternations of hot, cold and wet, dry, and a gap between eating and sleep. Reality did not always match the rulebook. Court and civic banquets were social performances that invited excess: many courses, multiple meats, thick sauces and generous wine service. Service tempos could be brisk, and diners of high status were expected to sample widely. When overindulgence occurred, households managed it discreetly. Halls were equipped with cloches and attendants tasked with rapid cleaning. Voiders, baskets, removed scraps. Servants escorted unwell guests from the board. Latrines, garderobes or side rooms provided a place to recover out of view. The expectation, however, was that vomiting at the table itself was a breach of decorum, not a sanctioned practice. The persistent modern claim that elites maintained special rooms to vomit between courses, the so-called Roman vomitorium, does not apply here. In Roman architecture, a vomitorium is a corridor in an amphitheatre that spews forth crowds. It was not a dining facility for induced vomiting. Medieval and early modern sources treat vomiting at banquets as a mishap or a consequence of intemperance, requiring apology and clean-up, not as an accepted phase of the meal. Physicians condemned prophylactic vomiting before or during a feast as medically harmful. Preachers condemned it as gluttony. Courtesy literature's silence on any legitimate tableside emesis is itself evidence that it fell outside acceptable behaviour. Household recipe books and stewards' manuals addressed overindulgence with non-dramatic measures. They recommend brief walking after supper, a small cup of warm diluted wine or hydromel, wafers or astringent fruits in proper order, e.g. quince or pear, to close the stomach, and early sleep in an upright or slightly raised posture. If a guest felt unwell, attendants provided tepid water and a basin in a private space. Only the mildest mechanical measures, a few draughts of warm salted water, brief stimulation of the fauces, were countenanced without a physician, and only the next morning fasting. Strong emetics remained in the physician-apothecary domain, not in the stewards. The social scripts around wine illustrate the same contrast between ideal and practice. Courtesy texts advise sipping rather than large gulps with food, reserving more generous drink between courses or after eating had progressed. In reality, toasting and entertainment pressured guests to drink frequently. The result, much liquid taken with solids, was precisely what regimen writers warned would quench the stomach's heat and create the heavy sour conditions that led to morning complaints. Where hosts took medical advice seriously, they adjusted service. More broths and lightly spiced dishes in winter, fewer thick sauces late at night, and a measured void rather than repeated rounds of drink. Institutions tried to enforce moderation with rules and staffing. Household ordinances assign the marshal and steward responsibility for pace and order. Kitchen rules specify portioning. Buttery and pantry rules limit uncontrolled access to drink during service. Hospitals and monasteries, which fed many people at once, were even stricter. Fixed rations, fixed times, and a supervised post-meal routine. These structures were not built around emesis. They were designed to minimize the circumstances that would make it likely. Physicians interacting with elite patrons bridged etiquette and therapy. Concilia routinely begin with a brief history. What was eaten, in what order, how late, how much wine, when symptoms began. Remedies then start with reform. Slower service, lighter late dishes, a walk after supper, before any talk of evacuation. If the familiar upper gastric cluster appeared the next morning, the physician authorized a single mild attempt at dislodgement, early and fasting, with strict stop rules and aftercare. If signs pointed lower, he chose lenitive downward remedies. In both cases, he paired the decision with explicit advice to stewards about menus and pacing to prevent recurrence. The practical outcome is clear. Table manners, service protocols, and post-meal customs formed the first line of defence against crudities. When they failed, households managed incidents discreetly and deferred anything beyond the mildest measures to professional oversight, and physicians framed any induced vomiting as a one-time corrective, not a feature of dining culture. Etiquette and medicine thus converged on the same message: manage overindulgence by design, not by normalising emesis at table. The etiquette-therapy alignment looked different in cities and at court because the food, service, alcohol and supervision differed. Physicians knew to read the setting when interpreting after-feast complaints. The symptoms could be similar, but causes and practical responses were not. Urban taverns and alehouses. City drinking places centred on ale, wine and a few reliable foods. A house pottage kept simmering, bread trenchers, cheeses, salted or pickled fish on fast days, and whatever small roasts or fried items the kitchen could turn quickly. Turnover was fast, benches were crowded, service emphasised drink over elaborate courses. Municipal rules, a size of bread and ale tasters, curfews aimed to control price and quality, not digestion. In this environment, the main risk factor was liquid with solids, large gulps with mouthfuls of bread or meat, which regimen writers said quenched the stomach's fire. On fish days, heavily salted herring or stockfish promoted thirst. Patrons drank more, compounding the problem. Mixing of many opposite dishes was less common than at court, but quantity of drink and late hours produced the same morning cluster: sour belching, coated tongue, epigastric weight, frontal headache. Taverns did not keep emetic drugs. If a patron became unwell, custom treated it as disorder. Wardens fined taverners for fouled floors. Staff removed the person to a side room or out to the street. The acceptable on-site remedies were modest: a seat near fresh air, a basin, perhaps a tepid drink, water, watered wine, and time. Anything beyond that belonged at home. Vernacular guides reflect this. After a heavy tavern night, the next morning's steps were early rising, gentle movement, tepid hydromel or salted water, and simple broths. If unmistakable upper gastric signs persisted, a single mild mechanical attempt, warm salted water and brief feather stimulation at home, fasting. Pharmacological emetics remained under physician-apothecary supervision and were not part of tavern practice. Social norms pushed the same way. Preachers and civic ordinances targeted tavern excess. Vomiting in public was evidence of intemperance, not a tolerated reset. Taverners managed reputation and floor cleanliness. They did not facilitate purging between cups. For craftsmen and porters who rose early, the cost of a disabling purge was high. Many opted for downward lenitives, prunes, figs, or simply regimen the following day rather than anything violent. Courtly kitchens and great households. By contrast, elite houses ran departmental kitchens, pantry, bread, buttery, drink, saucery, spicery, pastry, larder, scullery, capable of producing many courses with thick sauces, pies, and spiced wines. Carvers, sewers, and servers controlled tempo and order. Physicians and sometimes household apothecaries were present or nearby. Household ordinances coordinated diet, fasting days, and bloodletting calendars. Here, the principal risks were complex mixtures, rich sauces, and late service, which regimen literature explicitly linked to crudities. The after-feast profile that justified morning fasting, mild emesis, appeared more often in this milieu because the meal architecture created it. Even so, court norms did not normalize vomiting at table. Courtesy demanded discretion. Attendants removed unwell diners to a withdrawing room or chamber. The difference was access, not approval. A court physician could see a patron at dawn, prescribe tepid drinks, a single mild emetic if indications were clear, and oversee aftercare, broths, spiced waters, rest. The spicery stocked vehicles, oxymel, syrups, and correctives, aromatics, demulcents. The apothecary could compound squill preparations to standard. This infrastructure made the university sequence prepare, evacuate if indicated, restore practicable the same day. Menus were also adjustable. Physicians advising stewards recommended lighter late dishes, slower service, reduced sauce volumes, and a short post-supper walk for principals. On fish days, they urged fresh river fish over excessively salted imports late at night. Where patrons followed this advice, morning complaints decreased and emesis stayed exceptional. Where display trumped prudence, the familiar gastric cluster returned and physicians reached for the same mild morning measures with strict stop rules. Differing norms, different defaults. In cities, the default response to overindulgence was containment and recovery. Get home, sleep, rise early, take tepid drinks, and correct by diet. Only if signs clearly pointed to recent stomach load, consider a single mild upward attempt and avoid pharmacological emetics without medical oversight. In courts, the default was managed intervention. A physician reviewed the case at first light, decided among regimen, mild emesis, or downward remedies, and integrated aftercare and menu reform into the household routine. Both settings rejected prophylactic vomiting as a practice. Both saw public vomiting as a failure of restraint, not therapy. Physicians tailored advice accordingly. A merchant reporting a night of tavern ale and salted fish with morning heaviness might receive regimen first orders and at most a mechanical attempt. A noble reporting a multi-course meat and sauce feast with classic upper gastric signs might receive morning, fasting, mild emesis and stricter dish ordering going forward. In either case, the written concilium recorded the same guardrails. Early hour, empty stomach, one attempt, discontinue when relief appears, no repetition that day, and avoid cold water, raw fruit, and heavy meats afterward. Regulation reinforced the divergence. Municipal statutes policed tavern cleanliness and hours. They did not authorize drug dispensing. Great households maintained stores and staff who could implement medical schedules. Yet the therapeutic principle did not change. Least violent means first, only with indications, embedded in regimen. City or court, induced vomiting remained an exception, a targeted response to a specific kind of meal-made stomach problem, not a standing feature of urban drinking culture or courtly display. The The social message that vomiting should be exceptional found a parallel in preaching and pastoral care. Moralists treated gluttony as a capital vice and worked to separate medical remedy from sinful excuse. After the Fourth Lateran Council, 1215, standardized annual confession and pastoral instruction, handbooks for confessors and sermon collections gave clergy a common script: question the intention, the occasion, and the effect on others. If vomiting was provoked to permit renewed feasting or heavy drinking, it counted as gluttony. If it was ordered by a physician for a defined illness, taken once and followed by restraint, it was tolerated as necessitas, necessity. Pastoral manuals distinguished the species of gluttony in familiar terms later summarized by scholastics: eating too soon, too much, too eagerly, too expensively, or too daintily. Voluntary purging to make room mapped directly onto too much and too eagerly, and preachers folded it into Lenten sermons against banquet excess. Exemplar literature offered short cautionary tales. The courtier who took spiced wine and then forced vomiting between courses was punished not for vomiting per se, but for the intent to keep eating beyond measure. Confessors were instructed to ask whether the act was pre-planned before a feast, repeated habitually, or done publicly so as to cause scandal. Bad example. Any of those marks shifted the judgment from therapy to vice. At the same time, canonists and theologians recognized medical necessity as a legitimate qualifier. Fasting rules already allowed dispensations for the sick and pregnant. By analogy, a measured, physician-directed purge aimed at restoring digestion fell under permitted care. Pastoral handbooks advised confessors to ask practical questions aligned with university medicine. Was the person truly nauseated after a heavy meal? Did a physician order a single morning fasting attempt? Was there aftercare and subsequent restraint? Did the person avoid repetition the same day and amend food habits thereafter? Answers showing conformity to those limits supported absolution with light penance and advice on regimen. Monastic norms reinforced the line. Rules and customary books stressed portion control, fixed meal times, silence in the refectory, and a short walk after eating. Discipline that reduced the occasions for crudities without resorting to purging. If a monk became ill after a feast day, the infirmara might provide warm drinks and simple broths and call the physician. Prophylactic or repetitive emesis was treated as incompatible with monastic restraint. In some orders, the infirmary itself functioned as a gatekeeper. Anyone claiming sickness to evade fasting had to submit to supervised regimen rather than self-chosen measures, preventing the slide from remedy to excuse. Preachers also addressed public order. Civic authorities fined tavern disorder. Clergy condemned vomiting in streets or halls as a sign of intemperance and a cause of scandal, especially among elites whose behaviour set patterns for others. In that moral economy, even a medically justified purge belonged in private, at home or in chambers, not at the board. Physicians' own texts echoed this social logic. They paired any authorization of emesis with explicit advice about menu reform, slower pacing, and no repetition, thereby closing the route by which a cure could license future excess. Scholastic writers tied the moral and medical frameworks together through intention and proportionality. Thomas Aquinas' analysis of temperance provided a vocabulary. An act can share the matter of eating or evacuation while differing in end. Medicine aims at restoring order to the body, gluttony at disordered pleasure. Commentators then added practical tests that mirror clinical ones. Is the means least violent? Is the timing prudent, morning fasting not on feast days for show? Is the dose modest and the result relief rather than license? Do circumstances, pregnancy, age, weakness make the act unsafe, in which case even a therapeutic motive becomes blameworthy for imprudence? These questions gave confessors a way to police the edge cases without denying legitimate care. Household recipe books reveal how this moral stance filtered into lay practice. They include preparations for digestives, mint, fennel, anise, oxymel, and light electuaries, with marginal notes warning against violent upward drugs, except under a physician. Directions stress once-only attempts, early timing, and restraint afterward. Side by side appear reminders about fasting days, alms, and moderation, practical signals that the same book guided both bodily and spiritual discipline. In sum, moralists did not reject vomiting as such, they rejected its misuse. They aligned with physicians on three boundaries. First, no prophylaxis, inducing vomiting before or during a feast to continue eating is gluttony. Second, no routine. Habitual purging weakens the body and the will. Third, no publicity. Even where justified, the act belongs under discretion, not as a social practice. Within those limits, a physician-ordered time-boxed emesis for clear recent gastric overload could be excused as remedy. The net effect was to keep therapeutic purging in a narrow channel, clinically indicated, minimally violent, privately performed, and followed concrete reforms, so that what medicine permitted did not become what vice exploited. In religious houses, the same moral boundaries were tightened by rule and routine. Monastic medicine operated under assumptions of restraint, fixed meal times, prescribed portions, frequent fasts, and close supervision by the infirmarian. Within that framework, therapeutic purges, including emesis, were permitted only as exceptions for the truly sick, and even then they were scaled to minimize disruption of discipline. The rule of Benedict and its later observances set the tone. No meat of four-footed animals for the healthy, silence in the refectory, one principal meal on many fast days, and obedience to the superior's judgment in all dispensations. A purge that looked like a way to license richer eating was suspect on principle. Fasting practice shaped clinical choices. Monastic calendars layered Lent, Advent vigils, Fridays, Ember days, and numerous vigils of feasts. During strict fasts, the body was already understood as emptied and more fragile. Infirmarians therefore preferred non-evacuative corrections, rest, warm diluted wines or hydromel, light broths, mild aromatics, mint, fennel, anise, over any act that strained or dried the stomach. If a brother reported classic post-feast gastric signs after a conventual celebration, epigastric weight, sour eructations, morning headache, the first response was regimen. Earlier rising, gentle walking, tepid drinks, simple pottage. Only when symptoms clearly indicated recent matter retained in the upper stomach would a supervised, single, mild, upward attempt be considered, and almost always outside the strictest fast days to avoid compounding weakness. Institutional roles enforced this conservatism. The infirmarian controlled access to measures and materials. He maintained the herb garden, kept syrups and oxymel, consulted the house's physician, resident or visiting, for written orders and documented outcomes. The abbot prior granted dispensations that affected observance, permission to eat in the infirmary rather than the refectory, to take extra rest or to break a fast. Barber surgeons attached to larger houses bled monks according to tables, but were not the arbiters of purging by the mouth. This chain of authority made casual or repeated emesis difficult. A monk could not simply decide to clean out after a heavy meal without the infirmarian's and superior's knowledge. Monastic customaries also recognized how purges could be abused indirectly. After bloodletting, many houses allowed recuperation in the misericord, a separate dining space with relaxed diet, sometimes including meat or extra dishes. Critics occasionally noted that frequent bleeding could become a backdoor route to richer fare. That awareness fed suspicion of indulgent purges more generally. A vomit ordered once for clear gastric overload was one thing. A pattern of purging that predictably led to special meals and exemptions from fasts would trigger correction. In practice, this meant the infirmarian favoured downward lenitives or plain regimen for most digestive complaints, and reserved upward measures for unmistakable recent surfeit in otherwise strong brethren. Procedure, when emesis was used, followed the same standardized sequence taught in universities, with added monastic guardrails. Timing was early morning, fasting, in a quiet space under supervision. The house relied first on tepid salted water or diluted oxymel in measured draughts. Feather stimulation of the fauces might be tried once. Strong emetics, squill syrups, hellebroches, required a physician's prescription, and many houses lacked the apothecary capacity to prepare them on site. This logistical friction was a feature, not a flaw, discouraging escalation. Stop rules were strict. Cease at the first adequate evacuation and subjective relief. No repetition that day. Aftercare returned immediately to discipline, rinsing the mouth, rest in the infirmary, small portions of warm barley or chicken broth, avoidance of cold water and raw fruit, and a prompt resumption of normal observance once stable. Sources of supply and literacy reinforced restraint. Monastic physic gardens produced digestives and demulcents, mint, fennel, sage, plantain, quince, more readily than drastic emetics. Recipe collections kept by infirmarians emphasise syrups, oxymel, barley waters and potages, with marginal cautions against violent upward drugs, except under medical order. Bloodletting tables and simple lunaries, lunar phase notes, hung near the infirmary served mainly to schedule venesection and, by extension, any rare purge on safer days. They did not function as standing licenses to evacuate. When houses invited external physicians, their written consilia for monks read more restrictive than for lay patrons, more emphasis on regimen, narrower indications for emesis, explicit reminders about fasts and community scandal. The pastoral lens remained present even in clinical notes. Confessors in the house asked whether the act served health or appetite. Seniors watched for habits that signalled lack of temperance. Public decorum mattered. Any purging occurred privately, not in the refectory, and attendants handled mishaps quietly. Repetition without fresh indications drew admonition, not accommodation. Because the monastery's purpose the cultivation of obedience and temperance, medical advice that undermined those ends, by enabling cycles of excess and purge, lost legitimacy. There were differences among orders, but the pattern holds. Houses with elaborate liturgy and richer kitchens faced more occasions for heavy eating. Stricter observances reduced them. In both cases, the medical programme steered toward prevention. Portion control, correct dish order, a brief post-meal walk, and menu adjustments on feast days, lighter late dishes, fewer thick sauces. When prevention failed, emesis remained the last, least violent option for a narrow symptom cluster, not a convenience. In effect, monastic medicine trimmed the already conservative university protocol further. Evacuate rarely, only for clear recent gastric overload by the mildest means under authority, and with quick return to ordinary restraint. Outside the cloister, parish clergy used confession manuals to police the same boundary monastic medicine enforced. A one-off, physician-ordered purge for clear gastric overload could be tolerated. Anything that looked like license for excess counted as vice. After Lateran IV, 1215, mandated annual confession, handbooks such as Thomas of Chobham's Summa Confessorum, Raymond of Peñafort's Summa de Penitentia, John of Freiburg's Summa Confessorum, and Guido of Monte Rocherai's Manipulus Curatorum taught priests to interrogate intention, habit, and scandal whenever a penitent mentioned inducing vomiting. Confessors were trained to run through the standard circumstances, quis, quid, ubi, quibus auxiliis, cur, quomodo, quando. Applied to purging, the questions were practical and aligned with university medicine. Cur, why? Was the act done to continue feasting or heavy drinking, or to relieve a defined illness? A pre-planned purge to make room marked gluttony. A measured act after a physician's order counted as necessity. Quando, when? Was it done in the morning, fasting once, as physicians advise, or repeatedly the same day or at night in company? Timing signalled whether the aim was therapy or indulgence. Quomodo, mild household measures, tepid salted water, brief feather stimulation in a single attempt, differed from violent drugs taken without oversight. Excessive means against a fragile body could shift guilt to imprudence and self-harm. Ubi, where? Public vomiting at table created scandal, even if the motive was mixed. Causing offence increased the gravity. Quibus auxiliis, with what means? Was there a physician's prescription or only a tavern recipe? Manuals warned against drastic emetics, especially hellebore, without medical direction. Quis, who? Age, sex, and state mattered. Pregnant women, the elderly, and the sick fell under stricter caution. What might be tolerated in a robust adult could be gravely imprudent in them. The manuals linked outcomes to penances and counsel. If the confessor judged gluttony, purging to keep eating, or deliberate reset during feasts, he imposed a heavier penance and instructed concrete reforms, smaller late portions, corrected dish order, a short walk after supper, and no repetition. If the act followed a physician's order with early morning, fasting timing and was not repeated, confessors often assigned light penance and emphasized regimen to prevent recurrence. Where the act was habitual, they warned of two sins at once, gluttony and temporal harm to one's health, a violation of prudence and, in some analyses, of the duty to preserve life. Confession guides also addressed fasting. Because medieval calendars were thick with fast days, a common edge case was the person who ate secretly and then purged to appear compliant. Manuals classified this as simulation, hypocrisy, compounded with gluttony. Conversely, if a person broke a fast on medical advice and then used a measured purge to relieve clear crudities, the act fell under permitted dispensation. The confessor verified the physician's role and the one-time character of the remedy. Another recurring topic was occasional excess in different settings. For tavern nights, the council leaned regimen first: rise early, take tepid drinks, simple broths, avoid cold water and raw fruit, and do not escalate beyond a single mild household attempt. For courtly feasts with many courses and sauces, confessors advised the same dietary reform physicians gave stewards: slower service, lighter late dishes, and tolerated a single morning purge only when the classic upper gastric cluster persisted. In both settings, prophylactic vomiting, before or during the meal, was condemned outright. Manuals warned confessors to watch for secondary motives that turned therapy into excuse. If a penitent admitted that purging reliably secured access to richer fare, e.g. recuperation diets after frequent bloodletting or purges, the confessor was to curtail dispensations and direct the person back to ordinary fare once well. If a master or host encouraged others to purge so that drinking could continue, the manuals treated that as cooperation in sin and assigned penance proportionate to leadership and scandal. Astrology and superstition entered by the side door. Where penitents chose days for evacuations by lots, charms, or prohibitions unrelated to natural reasoning, some manuals counted this as superstition. Moderately, they allowed attention to lunar tables in the practical, medical sense, a waning moon as a safer moment, but rejected the idea that favourable stars authorised purging without indications. Confessors were told to separate adjunct prudence from credulous licence. Finally, confession books gave templates for counsel that mirrored the conservative medical sequence. A typical directive read: if nausea, sour eructations and epigastric weight follow a heavy meal, try regimen first: early rising, gentle walk, tepid hydromel, then one mild attempt at home if needed. Fasting: do not repeat that day, take light broths, avoid cold water and raw fruit, amend portions and order at future meals, consult a physician before any drastic drug. Anything else? Nighttime attempts, repeated provocations, public acts, or use as a standing tactic to keep eating was labelled vice. By channeling lay behaviour through these questions and scripts, confession manuals reinforced the same narrow corridor that monastic rules and university medicine defined. They did not redefine therapy, they filtered it, keeping induced vomiting private, rare, medically indicated and time-boxed, and denying sinners the cover of remedy when the facts showed an excuse. Those same filters tightened when the patient was a woman. University teaching, women's medicine handbooks associated with Salerno, the Trotula ensemble, and parish confession guides converged on a conservative rule set. Women were to be treated as more vulnerable to depletion, with stronger social constraints on what could be done, when and in whose view. In humoral terms, standard doctrine cast women as colder and wetter than men. That baseline implied slower coction in the stomach, a greater tendency to phlegmatic residues, and easier exhaustion by drying or straining measures. Therapeutically, it pushed practice away from violent evacuations, where a robust male patient with unmistakable post-feast upper gastric signs might be allowed a measured emetic after mild measures failed. Physicians were quicker to stop at regimen for women: early rising, a short walk, tepid hydromel, simple broths, or to choose lenitive downward remedies in small doses rather than provoke the upward route. Menstruation framed another boundary. Medieval medicine treated menses as a natural monthly evacuation that helped maintain balance. Many handbooks advised not stacking other purges on top of it. If a woman reported nausea and heaviness during her courses, the first line was correction of diet: warm, simple foods, avoidance of cold drinks, and modest aromatics: mint, fennel, anise. Induced vomiting was typically deferred unless the symptoms were clearly tied to a very recent dietary overload, and even then with extra caution. Scheduling mattered. Where a purge was otherwise indicated, it was moved away from menstruation to avoid disturbing the flow and further weakening the patient. pregnancy heightened caution. Texts repeatedly warn that emetics are dangerous in pregnancy because the strain and sudden abdominal and diaphragmatic pressure could threaten the fetus or precipitate bleeding. Nausea in early pregnancy, recognized as common, was managed with non-violent correctives. Tiny, frequent sips of warm diluted wine or hydromel, lightly acidulated waters, gentle aromatics in minute doses, and careful meal timing, small portions, more often. If strange cravings or persistent queasiness were reported, the advice emphasized bread or light foods on waking, avoiding long fasts, and absolute avoidance of drastic drugs. Mechanical tricks, feather to the fauces, repeated large draughts were generally discouraged for pregnant patients. If anything was attempted, it was a single, minimal trial under supervision and only for clear, immediate overload. The puerperium, post-childbirth, was another red zone. Women were considered depleted by blood loss and sleep disruption. Strong evacuations, including emesis, were postponed. Care focused on rest, warm broths, and gradual diet until strength returned. Where constipation or gastric discomfort followed childbirth, physicians preferred very mild lenitives and demulcents over anything that risked straining sutures or provoking hemorrhage. Lactation brought a further constraint grounded in humoral theory that milk is processed blood. Anything that reduced blood volume or quality, bleeding, harsh purgatives, repeated vomiting, was thought to diminish supply or alter milk. As a result, nursing women were steered toward dietary adjustments, more easily digested meats and grains, moderate fluids, and away from evacuations. If post-feast complaints occurred, the sequence stopped at regimen or, at most, a tepid drink and rest. Upward purges were avoided unless a physician judged them absolutely necessary and safe. Confession manuals and household norms amplified medical caution with social scrutiny. Vomiting in public already carried a stigma of intemperance. For women, expectations of modesty made public purging doubly problematic. Pastors instructed confessors to ask whether a woman's purge was private, physician-ordered, morning and once, or planned to permit continued feasting. The first could be excused as necessity. The second was classed under gluttony or deceit, e.g. purging to keep fasts in appearance. Manuals also flagged scandal, even where motive was mixed, causing offence by visible purging increased guilt. Practical consequence. Households moved any necessary measures to private chambers, and many cases ended with regimen alone. Status and setting shaped application. Elite women at court had ready access to physicians and apothecaries. Even so, written consilia for noble women are notably tighter. Narrower indications for emesis, explicit bans in pregnancy and nursing, and stronger emphasis on menu reform, lighter late dishes, careful order, slower service, to prevent recurrence. In urban settings where women managed kitchens and family diet, recipe books include oxymel, barley waters, and digestives with marginal cautions such as not for pregnant women or avoid in weakness, and they reserve anything stronger for medical direction. Among the poor, cost and access naturally limited escalation. Here the medical and social rules aligned with circumstance, correct by food, warmth and rest. Age and constitution intersected with sex. Adolescents and elderly women, both considered relatively cold and dry, were marked as poor candidates for emesis. Where intervention was unavoidable, it was minimal and supervised. Women judged hotter or more sanguine by complexion and pulse might tolerate a single mild attempt better, but texts still paired any authorization with tight stop rules and aftercare. Across these cases, the operative principle did not change. It was tightened. Diagnose the site, stomach or lower gut, match the route that removes the burden with least violence, and embed the act in timing, preparation, and aftercare. For women, especially during menses, pregnancy, puerperium, and lactation, that calculus almost always favoured regimen and lenitives over emesis, kept any upward purge strictly one-off and private, and tied medical permission to social restraint. The result was a narrower therapeutic corridor where remedy could not be mistaken for an excuse, and where the risks of depletion, to the woman herself, to the fetus, or to milk, overrode any temptation to treat vomiting as a routine solution to feast-made complaints. For children and the elderly, the therapeutic corridor narrowed even more than it did for women. Standard teaching cast both groups as weaker in heat and easily driven to dryness by strenuous measures. University handbooks, Salernitan summaries, and bedside consilia therefore defaulted to regimen and the mildest evacuations, reserving emesis for rare, unmistakably gastric cases, and then only with strict limits. Physicians began with temperament and strength. Children were described as naturally warm and moist but tender. Their digestive fire was lively yet easily disturbed, their bodies quickly exhausted by straining. Elderly patients were classed as cold and dry, digestion slow, reserves slight, recovery protracted. In both, induced vomiting risked faintness, syncope, excessive dryness, throat irritation, and, practically, poor cooperation. Accordingly, textbooks urged diet and routine first: earlier rising, a short gentle walk, tepid hydromel or lightly salted warm water in small sips, and light broths to encourage coction. If a purge was needed, the downward route, lenitive clysters, mild electuaries, generally took precedence over an upward one. Dose and vehicle were scaled ad aetatem et ad vires to age into strength. Apothecary forms were diluted and fractional, syrups thinned, electuaries given by the smallest spoonful, and anything sharp buffered with mucigenous vehicles, barley water, almond emulsion, quince. Writers advised halves or quarters of an adult portion as a starting point for older children, and drops to scruples for younger ones. For the elderly, less and slower was the rule, spaced over time rather than given at once. Potent emetics, white hellebore, strong squill, were generally excluded for both groups. If squill appeared at all, it was in a very dilute oxymel of squill, measured carefully and stopped at the first effect. Indications had to be unambiguous and recent. For a child, immediate heaviness after an obvious surfeit, sour eructations, coated tongue, a frontal headache after a late sweet and meat mixture, and no signs that the burden had passed into the lower gut. For an elder, the same cluster after a heavy evening meal, with caution that dizziness or weakness could mimic gastric discomfort. If lower signs dominated, retained stools, lower cramping, physicians redirected to lenitives, prunes, figs, small quantities of cassia, and especially to clysters, a common paediatric and geriatric tool, prepared mild, chicken broth, oil, a little salt, tepid and supervised. Mechanical measures were pared back. Feather stimulation of the fauces, so ordinary in robust adults, was treated warily in children, risk of panic, abrasion, and elders, risk of cough, laryngeal irritation. If attempted at all, it was once gently, with the patient seated forward, a basin ready and a second person steadying them. Large draughts were forbidden. The instruction was small, repeated sips of warm liquid to avoid sudden gastric distension. Manuals stressed stop rules. Cease immediately at the first adequate evacuation or any sign of pallor, dizziness, or chest discomfort. No repetition that day. Timing tightened safety. Morning, fasting, after adequate sleep remained the preferred moment, but neither group was to be kept long without food after the attempt. Aftercare began sooner and lighter, rinsing the mouth with tepid water or diluted wine, a short rest, then very small portions of warm barley or chicken broth. Cold water, raw fruit, and heavy meats were barred for the day. In winter, when bodies were judged colder and drier, many authorities postponed any emetic entirely for elders and small children, preferring warming regimen and, if necessary, a mild clyster. Common paediatric contexts, teething, worms, night sweets, drew extra caution. Writers warned against blaming every childhood nausea on crudities and forbade emetics as a routine response. The counsel was to simplify diet, correct timings, no sweet fruits late, and observe. For the elderly, frequent complaints of wind, slow stools and disturbed sleep called for walking, baths where available, and pottages rather than evacuation, unless the classic post-feast gastric cluster appeared clearly and recently. Supervision and setting mattered. Physicians preferred to visit in person before authorising any upward purge for these groups. If distance forced written advice, consilia were notably conservative. Regimen-only instructions, or at most a single trial of tepid salted water in very small quantities, with explicit orders to stop at the first effect and to call for help if none appeared. Apothecaries were cautioned not to dispense drastic emetics to guardians without a physician's written order. Moral and social filters, present for all, weighed heavily here. Public vomiting by children or the old Drew scandal, manuals directed families to handle any necessary measures in private and to reform the diet and pacing that caused the episode. Confessors, when asked, applied the same tests they used tension, habit and scandal, but added the question of prudence. Even with a therapeutic aim, was the act unsafe for this age, season and strength? If so, guilt attached to recklessness. Across these cautions, the operative pattern held: diagnose place, stomach versus lower gut, match the least violent route, dilute and reduce doses, watch timing and stop early. For children and the elderly, that usually meant no emesis, sometimes a single, minimal mechanical attempt under close watch, and far more often regimen and lenitives with careful aftercare. The aim remained the same: restore orderly coction without creating new imbalance, but the margin for error was smaller and practice adjusted accordingly. Differences in age and strength narrowed the safe options. Class and access narrowed them further. The same gastric complaint after a heavy meal played out differently in a great household, a town artisan's home, and a village cottage because the tools, people and ingredients available were not the same. In elite houses, a physician could be summoned at dawn. An apothecary or in-house spicery could produce standard vehicles, oxymel, syrups, and kitchen staff could execute aftercare, light broths, measured portions on command. Spice chests held pepper, ginger, cinnamon, cloves, grains of paradise, and sometimes sugar, costly imports that medical texts classed as digestives in small doses. These ingredients enabled the university sequence to be followed closely. Brief preparation, tepid hydromel, gentle walking, one measured attempt, mild mechanical method first. If ineffective and indications were clear, a controlled spoonful of squill syrup, and then structured recovery with broths and rest. Dose could be standardized because troches, syrups, and electuaries were compounded to recognized recipes. Stop rules and timing, morning fasting, no repetition, could be enforced by servants and supervised by the physician. Menu reform was also feasible. Stewards could slow service, cut sauce volumes, and adjust dish order to reduce recurrences. Urban middling households had partial access. Apothecaries operated in towns under guild rules and municipal inspection. Physicians were available, but cost mattered. Families often began with regimen-only measures taught in vernacular guides: early rising, a short walk, warm diluted wine or lightly salted water, simple pottage, and then decided whether to pay for a consultation. When a physician was consulted for unmistakable upper gastric signs after a feast, he might prescribe a mild mechanical attempt and, if needed, a small diluted dose of a standard syrup. The apothecary supplied it. But with budgets tight, many chose downward lenitives: prunes, figs, small quantities of cassia, or simply a day of broths and rest, rather than an emetic. Importantly, town ordinances usually restricted the sale of drastic emetics without a physician's order. This barrier kept violent drugs out of casual reach, channeling practice toward milder options. In peasant and rural settings, households relied on home cures and local plants. What they had ready to hand: grain for pottage, a little honey, vinegar, salt, garden herbs like mint, fennel, sage, plantain, dill, mapped well to the conservative regimen physicians preferred for most cases. A typical sequence after overindulgence was: rise early, take small sips of tepid salted water or diluted vinegar, honey, a simple oxymel, walk gently, and eat thin broth later in the morning. If nausea persisted and the signs clearly pointed to recent stomach load, some households attempted a single brief feather stimulation. Beyond that, escalation was uncommon. Strong emetics required an apothecary and money. Hellebore grown in gardens was known but feared. Sources repeatedly warn against unsupervised use. Distance to town also discouraged repeat attempts and encouraged patience with regimen. When lower gut signs predominated, the go-to was a mild clister where knowledge and means existed, or prunes and oil rather than anything upward. Access also determined the form of medicines. Elites consumed syrups, troches and electuaries made to measured recipes. The poor used decoctions and kitchen vehicles. The same theoretical agent, squill, for example, took safer forms for the rich: a standardized oxymel of squill, doled by spoon, and a cruder, riskier form if improvised without proper compounding, which texts discourage. Conversely, some effective correctives were cheapest. Tepid water, thyme, and a plain broth are exactly what university medicine recommended first. In this respect, poverty sometimes aligned with prudence. Fewer opportunities to overuse spices, syrups, or repeated purges meant fewer iatrogenic problems. Aftercare showed similar stratification. Great houses could assign rest, prepare barley or chicken broths on schedule, and police forbidden items, cold water, raw fruit, heavy meats for the day. Urban families did a simpler version, a day off, heavy labour if possible, watered wine or hydromel and a thin pottage. Rural households returned to work sooner. The aftercare was often just timing and restraint, no cold well water, no raw fruit, and a lighter evening meal. Social oversight differed too. In courts, physicians could write consilia that doubled as management memos for stewards. Slower pacing, lighter late dishes, fewer thick sauces, reducing future incidents. In towns, confession manuals and civic preaching bore more weight, publicly condemning tavern excess and prophylactic vomiting. In villages, custom and scarcity were the regulators. There were fewer multi-course feasts and drink was constrained by work and daylight. Across settings, public vomiting remained a stigma. Any necessary measures were moved into private spaces, reinforcing the rule that emesis, when used at all, was exceptional and discreet. Finally, class-shaped risk. Elites could afford physicians and apothecaries, which reduced the danger of misdosing, but increased exposure to rich menus that caused the problem. The poor faced fewer engineered feasts, but more salted staples, e.g. herring, that promoted thirst and indiscriminate drinking, another route to crudities, yet they also defaulted to the least violent medical responses. In all strata, the safest path echoed the university message: reserve-induced vomiting for rare, clear, recent stomach-seated overload. Begin with regimen, use measured means once if needed, and return immediately to ordinary diet and restraint. Access determined how precisely those steps could be implemented, not the underlying rule that emesis was a targeted correction, not a routine tool. Access determined how precisely households could follow the least violent, once-only protocol. And behind that access stood the apothecary supply chain. Urban apothecaries stocked what local gardens could grow, what regional collectors could gather, and what long-distance merchants could import. That chain decided not only whether an emetic or corrective was available, but in what form, at what strength, and at what price, which in turn shaped physicians' prescribing habits and patients' willingness to use anything beyond regimen. At the base were physic gardens, monastic plots, hospital gardens, and small urban beds tended by apothecaries themselves. These supplied common digestives and correctives, mint, fennel, anise, sage, demulcents, barley, plantain, quince, and some emetic or adjunct species in regions where they grew, various hellebores with strict species distinctions in better shops, and more rarely locally obtained squill near suitable coasts. Because garden output was seasonal and potency varied by harvest conditions, reputable shops dried, sorted and stored simples in labelled jars, rotating stock to avoid loss of strength. This local tier underwrote the conservative practice. Even when strong emetics were scarce or avoided, apothecaries could always provide oxymel, barley waters, and aromatic waters that enabled mild, safer interventions. Beyond the garden came regional gathering and wholesale fairs. Country collectors brought roots, barks and seeds to market towns and to major fairs, e.g. in Champagne or along the Rhine, where apothecaries purchased in bulk. Here the risk of adulteration rose. Cheaper substitutes exhausted lots rescented with aromatics or misidentified roots. Guild statutes and civic ordinances tried to police this with inspections, standard weights and occasional burnings of bad stock. Practical testing, taste, texture, colour, behaviour in water or vinegar formed a shop's first line of quality control. Because potency and purity determined dose and dose determined safety, the conservative dosing rules in university commentaries assume this variability. Start mild, escalate only when necessary, stop early. The critical tier for potent agents was long-distance import. Squill, Scilla drimia, circulated widely from Mediterranean coasts, typically arriving dried and later processed into oxymel of squill, a controllable syrup that physicians preferred when an emetic was truly indicated. Other cathartics used as alternatives or complements: senna, Alexandria, Levant, rhubarb via the Black Sea or later overland, aloes, Arabia, Africa, scammony and colocynth, Levant, moved through Italian maritime hubs, Venice, Genoa, into northern Europe. Sugar, still costly in much of the Middle Ages, affected affordability. Many syrups and electuaries that moderated harsh drugs depended on honey or sugar as vehicles. Where sugar was dear, honey-based vehicles dominated, shaping flavour and shelf life. Disruptions, wars, embargoes, piracy, plague shifted prices sharply and could remove standard preparations from the market for a season or more. Physicians then leaned harder on mechanical methods and dietetic correctives because the safest pharmacological forms were unavailable or unaffordable. Price and credit structured everyday decisions. Apothecaries extended credit to elite households and institutions. Artisans paid cash. Peasants often did without or bought only the simplest items, vinegar, honey, salt, from general merchants. Potent emetics such as white hellebore in troughs or measured powders were relatively inexpensive per dose, but expensive in risk, so shops favoured buffered forms and small counted portions. Squill syrups cost more upfront because they consumed vinegar, honey, sugar, fuel and time, but they bought dose control and predictability, which physicians valued. In this way, market prices nudged therapy toward or away from certain options without altering the underlying rule set. Formulation practices reflect the supply chain. The widely copied antidotaries specified standard forms, syrups, oxymels, electuaries, troches, precisely because they converted variable raw plants into repeatable units. Apothecaries invested in balances, graduated vessels, and controlled boiling to hit the signs of proper syrup, thread, pearl stages. For emesis, this meant that a spoon of squill oxymel in a great house could be reproduced the next month with similar effect, while a rural household's improvised decoction could not. Where sugar was scarce, syrups were thinner and spoiled faster, shortening shelf life and pushing shops to smaller batches and higher prices. Regulation and shop practice further constrained risk. Many cities forbade apothecaries from dispensing violent drugs without a physician's written order. Inspectors checked weights and sometimes sampled stock. Guild training emphasised identification to avoid substituting black for white hellebore, storage, dry, dark, away from pests, and labelling. Apothecaries kept daybooks recording prescriptions and quantities, useful for tracing outcomes and for defending against accusations of malpractice. This institutional layer supports why university medicine could safely recommend a measured once-only emetic in select cases. The pharmacy system could deliver a predictable product, and civic oversight deterred reckless retailing. Supply realities also explain many therapeutic preferences. Where squill was common and affordable, coastal regions with strong Venetian links, physicians more often prescribed a modest buffered emetic when indications were clear. Inland, far from reliable imports, writers leaned on mechanical measures and downward lenitives, reserving any upward purge for exceptional cases, and even then preferring tepid salted water over scarce, risky drugs. In times of shortage or high prices, Concilia emphasised regimen, timing and aftercare even more strongly, illustrating that the least violent first rule was not just ethical caution but supply-savvy practice. Finally, markets affected patient expectations. Elites accustomed to syrups and electuaries expected rapid, tidy results. Physicians met that expectation within the guardrails, morning fasting, one dose, stop early, broths after. Townspeople bargained between cost and convenience, often accepting regimen-only plans unless symptoms were severe. Rural patients defaulted to home cures not only from prudence, but because the logistics of obtaining and trusting a potent emetic were daunting. Across these strata, the pharmacy and trade systems made it possible, but not inevitable, to use emetics safely. The conservative medieval protocol endured because it fit the market. Gardens guaranteed mild correctives. Imports, when present, supplied standardised forms. Prices and regulation discouraged casual escalation. The result was a supply chain that quietly reinforced the therapeutic message. Reserve induced vomiting for rare, unmistakably gastric cases, use measured, buffered preparations, and embed the act in preparation and aftercare. Because the trade in standardised syrups and troches made potent emetics available, university medicine kept repeating a blunt rule: dose makes the poison. Nowhere was that clearer than with hellebore. Commentators distinguished white hellebore, the classic violent emetic, from black hellebore, more often a downward purgative, but they also warned that shops sometimes confused species or sold exhausted stock. Even when identification was correct, small differences in drying, storage or age altered strength. Hence the insistence on tiny measures, buffering vehicles and stop rules, and the readiness to use squill oxymel or purely mechanical methods instead when a case did not clearly justify the risk. Physicians framed hellebore as a last step after milder attempts failed, and only when signs located the burden in the stomach and recent post-feast heaviness, sour eructations, coated tongue, frontal headache without lower gut signs. The order written to the apothecary specified weight, vehicle, timing and termination. A few grains in troche taken morning and fasting, mixed into barley water, honeyed water, or almond emulsion to blunt harshness. Discontinue at the first adequate evacuation and subjective relief. For the robust adult only, exclude children, the elderly, pregnant or newly delivered women, and the already weak or thirsty. Many texts add, do not repeat the same day, reassess with regimen. Hazards were categorized in the same practical vocabulary used for all evacuations, but with greater emphasis. First, excessive violence, retching beyond the expulsion of food and acrid fluids, continuing until only watery mucus appeared, counted as harmful drying. Warning signs included pallor, cold sweat, faintness, a small feeble pulse, trembling, and a sense of sinking. Second, throat and chest irritation. Harsh drugs could inflame the fauces and provoke cough. In persons with chest ailments, that danger was reason enough to avoid upstream purges altogether. Third, collapse through depletion, when the act emptied not only the offending material, but also the body's strength. Writers advised attendants to watch the face and hands and to stop at the first signs of swoon rather than pursue a predetermined number of efforts. The aftercare attached to hellebore was correspondingly strict. The patient rinsed the mouth with tepid water or diluted wine, then rested in a quiet, airy space, seated or reclined, not flat. Small sips of warm drinks, barley water, lightly spiced waters followed, with light broths later. Cold water, raw fruit, sour or heavy foods were forbidden for the day. If lightheadedness or chill persisted, a little warm diluted wine might be permitted. If the pulse was weak, the physician reconsidered whether the initial indication had been too aggressively pursued. No second dose the same day was a near universal rule. Dosing practices revealed the profession's caution. Apothecaries shaped hellebore into troches to prevent accidental overmeasure. Physicians prescribed grains and scruples, not spoonfuls, and often divided the intended amount, allowing a pause to observe effect before any addition. Vehicles were chosen to moderate barley's softness, almonds' oiliness, honey's viscosity, on the premise that the same drug in a gentler vehicle would bite less and expel what was needed without tearing at the stomach. Some recipes paired a trace of hellebore with aromatic digestives, ginger, anise, fennel, in minimal quantities to open obstructions while keeping the emetic power in check. Case literature and concilia show how quickly physicians abandoned hellebore at the first hint of excess. If the patient became markedly thirsty, dry-mouthed or dizzy after the initial efforts, the plan reverted to rest and broths, not to stronger repeats. If a mistake had been made, too large a dose, or a misread indication, the recommended remedy was time and nourishment, not another purge to correct the first. Where faintness ensued, attendants were told to loosen clothing, fan, offer aromatic waters to the nose, and allow recovery before any further treatment. The point was to save strength, since strength, not emptiness, was understood as the foundation of recovery. Writers also emphasized season and constitution as dose multipliers. In winter, cold, dry, hellebore's drying power was more dangerous. In summer's peak heat, hot, dry, depletion came faster. In the cold and dry, the elderly, melancholic temperaments, those weakened by prior bleeding, hellebore was almost always contraindicated. Even robust patients were told to avoid baths, heavy labour and sun after dosing, on the view that combined drying measures led to collapse. Supply chain realities added two further risks. First, adulteration. A troche too weak might tempt repetition. A troche too strong could overwhelm. Guild inspection and shop reputation mitigated but did not eliminate this. Second, misidentification, confusion between white and black hellebore or between hellebore and unrelated roots, appears often enough in warnings to have been a real concern. Hence university teaching's preference when possible for squill oxymel with a broader safety margin or mechanical measures, saving hellebore for the unmistakable case under close supervision. Finally, moral and legal controls supported clinical caution. Many towns barred dispensing violent drugs without a physician's written order. Physicians themselves were judged on outcomes. Repeated collapses after their prescriptions brought reputational harm. Preachers condemned the habitual use of emetics as a vice, further discouraging casual repetition. All three, shop law, professional accountability and moral pressure, worked with the clinical maxim that the purpose of evacuation is to restore coction, not to empty the body at any cost. In practice, that meant hellebore rarely appeared, and when it did, it came in small, buffered one-time doses, surrounded by preparation and aftercare, with attendants ready to stop at the first sufficient effect. Given those hazards, medieval therapy treated aftercare as part of the prescription, not an optional add-on. Physicians expected households to follow a structured sequence immediately after any induced vomiting, especially if a drug like squill or hellebore had been used, so that coction could resume without relapse or depletion. The first element was rest and posture. After the last effective effort, the patient rinsed the mouth with tepid water or diluted wine, then rested in a quiet room, seated or slightly reclined, not flat. The aim was to avoid strain on breathing and to reduce the chance of renewed gagging. Attendants were told to watch for pallor, dizziness, cold sweat, or trembling, signs to stop all measures and allow recovery before offering anything by mouth. Heat sources were moderated, no hot bath that day, too drying, but a warm cloak or bed covering if the patient felt chilled. Next came rehydration with mild vehicles. Texts recommend small, spaced sips, rather than large draughts. Barley water decoction of pearl barley, hydromel, honey water, or diluted wine warmed to tepid. These drinks were chosen for function, barley for softening and demulcent effect, honey water for gentle energy and to smooth the stomach, diluted wine for light stimulation in the chilled or faint. Cold water was consistently forbidden. It was blamed for quenching the stomach's heat and fixing residues to the wall of the stomach. The rule was incremental, a few mouthfuls, pause, observe. Continue only if lightness and calm persisted. When fluids were tolerated, households introduced light broths and pottages. The standard options in both learned and vernacular guides were barley broth, chicken broth skimmed of fat, thin oat gruel or almond milk thinned with warm water. The idea was to supply moisture and modest nourishment without challenging the stomach. Smooth textures, little fat, no sharp acidity. Seasoning, if any, used minute quantities of warming aromatics, ginger, cinnamon, anise, fennel, on the premise that mild warmth opened obstructions and supported coction. Physicians cautioned against heavy bread, thick meat pottages, egg-rich sauces or sour fruits on the same day. Those belonged to the following days once appetite and strength returned. Warming spices were treated as correctives, not cures. Recipes for digestive waters or spiced waters, a few seeds of anise or fennel steeped and strained, appear in household books with tiny dose instructions, a spoon or two, and explicit warnings to avoid peppery heat or large pinches that would irritate the throat or spike thirst. Where Hippocras spiced wine was permitted, it was diluted and warmed, taken in a small cup, and never as a license to resume feasting. Physicians framed these aromatics as adjuncts to broths and rest, not a standalone treatment. Movement was staged. For the first hours, quiet was preferred. Later the same day, if the patient felt steady, a short, gentle walk was advised to restore ordinary movement of humours without provoking sweat or strain. Heavy labour, long walks, riding or heat, sun, furnace, bath, were deferred to the next day or later, depending on strength. Sleep was encouraged the following night, with the head slightly raised. Lying down immediately after broths was discouraged. Diet over the next 24 to 48 hours followed a ladder. Day 0, the day of emesis, tepid drinks by sips, then thin broths or gruels in small portions at intervals, no raw fruit, cold drinks or heavy meats. Day 1, if appetite returned and there were no signs of relapse, sour eructations, heaviness, headache, add soft bread soaked in broth, poached chicken or light fish, still avoiding thick sauces and strong acids. Day 2, gradual return to ordinary fare, with smaller portions and slower pacing, and with attention to dish order, lighter to heavier, astringents late. Patients were told to avoid repeating the purge to feel cleaner. The measure was complete once relief appeared. Signs of adequate recovery were practical. A feeling of lightness in the epigastrium, calm breath, clearer tongue and the absence of head heaviness or sour belching. Warning signs that triggered re-evaluation were persistent thirst, continued retching of clear fluid, weak pulse, vertigo, or pain in throat or chest. In such cases, the instruction was not to medicate further at home, but to seek a physician. Additional purging was classed as harmful. Institutions supported this regimen. Apothecaries dispensed oxymels and syrups with written directions that included aftercare steps. Infirmarians in monasteries and hospitals kept broths ready and posted do not lists: no cold water, no raw fruit, no heavy meats. Household stewards coordinated menus to match recovery: barley pottage at prime, thin chicken broth at terse, rest, then a small portion of soft food later in the day. Confession manuals reinforced restraint by condemning attempts to use convalescent status to obtain richer fare. Class and access changed the form, not the logic. Great houses used clarified broths and almond emulsions. Townsfolk used simple potages and watered wine. Villages relied on barley or oat gruel and kitchen herbs. Across settings, the message matched university teaching. Aftercare is the second half of the treatment. It replaces what evacuation risks removing: moisture, warmth and orderly movement, and prevents the common failures: chilling the stomach with cold drink, reloading it with heavy food too soon, or provoking a second purge out of impatience. Finally, aftercare closed the loop back to prevention. Written consilia routinely appended menu corrections and pacing rules to the aftercare plan, so the next feast would be less likely to produce the same gastric burden. In effect, broths, mild aromatics, rest and gradual foods were not merely convalescent comforts. They were standardized safeguards that made a one-time indicated emesis compatible with the larger aim of regimen: stable digestion, moderate appetites, and no repetition of violent measures. Having treated emesis as a narrow one-time correction for recent stomach overload, physicians set it alongside other means of restoring balance. Foremost among these was bloodletting, opening a vein or using leeches, chosen when signs indicated plethora and heat in the vascular system rather than undigested matter in the stomach. The decision turned on location and qualities. If the problem was in the stomach, nausea, sour eructations, epigastric weight, post-feast headache, emesis was considered. If the patient showed general fullness, flushing, abounding pulse, throbbing temples, redness, inflammatory pain, or a fever judged hot and full, physicians preferred to reduce quantity and heat by taking blood. University teaching organised this into a sequence. When a patient presented acutely hot and tense, many masters advised bleeding first to blunt danger, then reassessing for any digestive intervention once heat fell and signs of coction appeared. In contrast, if a patient had no systemic heat but obvious upper gastric signs after a banquet, a mild morning emesis could precede any thought of bleeding. When the picture mixed head symptoms with heat, headache, congestion, red eyes, authors often recommended a measured venesection from the arm or local depletion, cupping, scarification, or leeches near the affected territory, rather than stirring the stomach. Technique and personnel differed from emetics. Barber surgeons commonly performed venesection under a physician's order. The standard sites were the median cubital region of the arm, cephalic or basilic, sometimes the saphenous vein at the leg. For facial congestion, some texts allowed bleeding from the cephalic side to draw from the head. Instruments were lancets and bowls marked for volume. The act was brief and observable: a cut, a controlled flow, compression and dressing. Leeches offered a slower local alternative where precise derivation was desired, around inflamed piles, near a tense, inflamed joint, or at the temple for ocular congestion. Apothecaries and country collectors supplied leeches. Removal was by salt, vinegar, or ash when they did not release spontaneously. After either method, attendants applied pressure, wool or lint, and astringent washes, vinegar, water, or alum solutions, then enforced rest and light diet. Indications and contraindications were drilled as rules. Bleeding suited robust adults with clear signs of heat and fullness, in spring especially, which regimen writers paired with sanguine excess. It was avoided in the very young, the elderly, the pregnant, the recently delivered, and the already pale or dry, small, feeble pulse, cold extremities. Active throat or chest fragility, recent blood loss, and winter's cold, dry qualities also argued against it. For fevers, authorities repeated the Hippocratic caution to time strong evacuations with coction, yet many still bled early in sharply plethoric, burning cases to avert complications, postponing any purge of the gut until the patient stabilised. Astrological and calendrical checks used for all evacuations appeared here as well. Bloodletting tables marked favourable days. Authors advised avoiding the full and new moon and days when the moon was in the sign governing the part to be treated, e.g. Aries for head. These were secondary guardrails, useful when cases were elective or preventive, waived when danger pressed. Seasonal counsel matched the practical physiology. Larger or repeat bleedings were scheduled in spring-autumn, rarely in deep winter or peak summer, unless necessity compelled. The rationale for choosing vein over stomach lay in the target. Emesis emptied the stomach and removed acrid gastric bile. Bleeding reduced mass and heat in the blood and relieved pressure at inflamed sites. Typical armchair cases in Consilia read accordingly. A courtier with a late multi-course feast and morning nausea, sour belching and epigastric heaviness, try regimen, then one mild emetic if needed. A merchant with pounding temples, flushed face, tense pulse, and burning chest after days of heavy meats and little sleep. Open a vein, take a measured quantity, rest, then adjust diet. No emesis unless subsequent signs pointed clearly to gastric burden. A townsman with a red, swollen, painful joint, leeches or cupping locally in diet correction, not stomach purging. Dosing in bleeding mirrored the dose makes the poison principle taught for hellebore. Physicians specified how much to take by ounces or by stopping at a change in colour pulse, watched closely for pallor, dizziness or fainting, and laid down stop rules. Rebleeding the same day was discouraged except in emergencies. Any further depletion, baths, long walks, sun, was barred for 24 hours. Aftercare paralleled post-emesis protocols. Tepid drinks by sips, light broths, no cold water, no heavy meats, and rest. If the initial goal was to temper heat, some advised a cooler but nourishing regimen the next day. If the patient ran dry, warming demulcents took priority. Leeches carried their own risks: excessive or prolonged ooze from the bite, local infection, and improper placement. Manuals instructed an exact count, limited time on the skin, and astringent dressings afterward. For ocular and facial use, they warned to avoid visible veins and to monitor carefully. For hemorrhoidal bleeding, to protect adjacent tissue with ointments, and to stop promptly if flow exceeded expectation. Social and legal controls supported restraint. Many cities licensed barbers and inspected apothecaries. Public authorities circulated bleeding calendars but penalised disorderly practice. Preachers criticised fashionable bleeding as a convenience to access richer foods during convalescence, paralleling their condemnation of purging as a feast licence. Hospitals and monasteries scheduled quarterly bleedings under supervision and coupled them with measured diets in the misericorde, trying to prevent therapeutic allowances from becoming indulgence. Supply and access influenced choices but did not change the rule set. In regions far from reliable emetic imports, physicians leaned more on bleeding and downward lenitives in hot, full cases, reserving emesis for unmistakable stomach burdens. Where leeches were plentiful, marshy districts, local depletion was more common for inflamed parts. In elite houses, staff and equipment made venisections safe and observable. Among the poor, distance and work needs encouraged smaller single bleedings, if any, and greater reliance on diet and rest. In summary, opening a vein rather than the stomach followed the same conservative logic. Identify the dominant problem, heat and plenitude in the blood versus recent crudities in the stomach. Choose the nearest, least violent route, and embed the act in timing, aftercare, and prohibition of repetition. When heat and tension led the picture, bleeding or leeches were the primary tools. When the burden sat in the stomach, emesis remained the targeted exception. Between those poles sat the downward therapies: oral laxatives, clysters, enemas, and sweating, used when signs pointed to burden in the lower gut or to viscosity and obstruction better relieved below than above. University handbooks framed the choice as place and quality. If nausea, sour eructations, and epigastric weight after a feast implicated the stomach, consider a one-off mild emesis. If retained stools, lower cramping, flatulence, and a sense of weight in the hypergastrium dominated, send matter downward. In plethoric hot cases, bleed first, Then reassess whether a lenitive purge or mild sweating should follow once heat had fallen and signs of coction appeared. Laxatives were graded from lenitives to stronger purgatives. The lenitive end aimed to soften and lubricate prunes, figs, raisins, cassia fistula pulp, diacatholicon, a standard electuary combining mucilaginous and sugary agents, oil of sweet almonds, and barley-based preparations. These were given to children, the elderly, and the convalescent, and to anyone with dryness or weakness. Vehicles mattered. Honey, or where available, sugar syrups, almond emulsions, and barley water buffered sharpness and reduced griping. Doses were fractional, a spoon at intervals rather than a bolus, so the physician could stop at the first easy stool. Stronger purgatives, senna, rhubarb, scammony, colocynth, were reserved for more stubborn constipation or for cases theorised as black bilious obstruction. Even then, writers insisted on preparation, a day or more of softening diet and warm drinks, timing, morning, fasting, admixture with correctives, a trace of fennel, anise or ginger to open without overheating, and stop rules. Repeating a strong purge the same day or stacking it up of bleeding was discouraged except by explicit order. Contraindications echoed those for emesis, pregnancy, late age with dryness, active inflammations, and any picture of dehydration. Clysters offered a direct local route when the lower bowel needed softening or when oral agents were undesirable, nausea, poor cooperation, fragile stomach. Equipment ranged from a bladder and pipe to piston syringes in better-equipped households and hospitals. Standard recipes were tepid and gentle. Chicken or mutton broth mixed with olive oil and a pinch of salt, additions of mallow, chamomile or linseed for demulcent effect, occasionally a small amount of honey to draw fluid. The technique was to warm the liquid to body temperature, oil the pipe, place the patient on the left side or in a knee-chest posture, infuse slowly, and have them retain the fluid as long as comfortable before expelling. Children and the elderly especially benefited from clysters because dose was controllable and systemic strain low. Sharp or irritant clysters appear in texts but are fenced with warnings. The mainstream practice favoured emollient mixtures first. Indications for clysters included hard stools, post-feast stasis that had clearly descended, post-febrile intestinal dryness, and situations where oral purgatives were likely to provoke vomiting or could not be kept down. They were avoided in acute lower gut inflammations, severe pain, fever, bloody stools, until a physician judged them safe, and they were not combined with other depleting measures the same day. Sweating, sudorifics, straddled hygiene and therapy and was often coordinated with bathhouse routines. The aim was to open the pores, thin humours, and relieve minor obstructions without forcing the stomach or bowels. Methods ranged from dry sweating, bundling near a stove, to moist sweating, steam rooms, scented vapours, and tepid baths followed by wrapping. Physicians timed sweating after signs of coction in fevers or after a light meal in non-febrile patients, and they capped duration to avoid collapse. Aromatic additives, sage, rosemary, bay, were used in small amounts in vapours, more for perceived opening than for pharmacological punch. Sweating was contraindicated in the very weak in advanced age during winter dryness, and immediately after bleeding or purgation. Stacking depleting measures was a recurring warning. Bathhouse culture gave these practices an institutional home in many towns. Public and private stoves, Steuben, étuves, offered graded heat, washing, rubbing and rest. Physicians wrote consilia that used this infrastructure conservatively. A short tepid bath, gentle rubbing, a brief sweat, then rest and a light broth. No sudden plunges into cold water, no prolonged heat in peak summer, and no baths for those with active chest complaints unless specifically advised. As with all evacuations, the morning was preferred, allowing observation and recovery during the day. Across these downward routes, the same logic governed choice and sequence. If the picture was hot and full, take blood first. If lower obstruction dominated, begin with lenitives or an emollient clyster. If minor viscosity and chill were suspected without clear gut burden, try short, controlled sweating. Only escalate to stronger purgatives when milder steps failed and when constitution, season and supervision allowed. Stop rules applied. Cease at the first easy stool or adequate sweat. Do not repeat that day. Proceed to aftercare. Tepid drinks by sips, light broths, avoidance of cold water and heavy meats, and a gradual return to ordinary diet. Risk management paralleled that for emesis and bleeding. Adverse signs: griping abdominal pain, excessive thirst, dizziness, feeble pulse, persistent ooze from leach sites if combined with local depletion, triggered rest and re-evaluation, not additional purging. Confessors and moralists added the same guardrails. No habitual purging to license indulgence, no public displays that caused scandal, and no prophylactic measures to make room. In practice, the downward routes allowed physicians to manage many complaints without touching the stomach, reserving induced vomiting for the narrow case to which it properly belonged. Set against purges and bathhouse measures, diet and regimen were the baseline treatment, what physicians expected households to practice so that evacuations would rarely be needed. University teaching framed this under the 6 Galenic non-naturals: air, food and drink, sleep and wakefulness, motion and rest, excretion and retention, and passions of the soul. Managed together, they were meant to keep digestion steady, orderly coction, and to prevent the crudities that later forced more active interventions. Food and drink. Text recommended 2 structured meals where circumstances allowed, a larger midday dinner and a lighter earlier supper, leaving hours between eating and sleep. Portions were to be modest, with dishes served from lighter to heavier, and astringents, wafers, quince, pears at the end to close the stomach. Raw fruit was treated cautiously. Cooked fruit or conserves were preferred, and raw fruit late at night was discouraged. Sauces were allowed in small quantities. Spices, ginger, cinnamon, anise, fennel, were classed as digestives when used sparingly. Cold water with food was consistently discouraged. Tepid drinks or watered wine were safer, with the bulk of liquid taken between rather than during mouthfuls. In winter, when bodies were judged colder and drier, physicians favoured warm, moist foods: broths, pottages, stewed meats. In peak summer heat, hot, dry, they advised lighter fare, avoiding strong drying measures that could deplete. Sleep and wakefulness. The rule was adequate night sleep, avoidance of late suppers, and no lying flat immediately after eating. A short post-meal walk was standard advice to set the stomach and discourage vapours rising to the head. Daytime naps were permitted in moderation, brief and not directly after a heavy meal. Nighttime waking for entertainment, especially after banquets, was marked as a common cause of morning complaints. Motion and rest. Regular moderate exercise, walking, riding at an easy pace, light manual work, was credited with assisting coction and bowel movement. Heavy labour or athletic exertion immediately before or after meals was discouraged. Where bathhouses were available, tepid baths followed by gentle rubbing and a short rest could substitute for outdoor motion in winter, but manuals warned against long soaks or extreme heat that left the body dry and faint. Air and setting. Physicians noted stuffy halls, smoke, and crowded taverns as aggravating factors. They preferred cool, clean air at night and ventilated rooms for sleep and convalescence. Seasonal counsel included warmer clothing and avoidance of damp chills in winter and shade and reduced exposure to midday heat in summer, both to protect the stomach's fire. Excretion and retention. Regular stool and urine patterns were treated as signs that regimen was working. Households were told not to suppress natural urges. Forced retention was blamed for later obstructions. When stools slowed, the first line was dietary softening: broths, almond emulsions, prunes or figs before any pharmacological purge. In this way, regimen absorbed many complaints that might otherwise have been sent to the clyster or the apothecary. Passions of the soul. Emotional extremes, anger, grief, fear, were recognised as direct disruptors of digestion. Courtesy and pastoral literature overlapped with medicine here. Quiet conversation at table, avoiding quarrels, and post-meal restfulness were recommended as part of therapy. Physicians linked restless nights and anxious debates to the very head heaviness and sour eructations patients reported after feasts. Daily practice combined these strands into a repeatable schedule. A typical household plan for someone prone to after-feast complaints ran: early rising, tepid hydromel in small sips, a short walk, a midday main meal beginning with lighter dishes, then moderate meat or fish with modest sauce, a brief walk, routine work, and a light early supper: broth, soft bread, perhaps poached chicken or river fish, followed by quiet and timely bed. If invited to a heavy evening meal, the person was counselled to pace portions, chew thoroughly, limit drink with bites, and take a short stroll before sleep. The next morning's regimen, even without symptoms, favoured tepid drinks and light pottage to stabilise coction. Physicians formalised this into written consilia that prescribed weeks of regimen in lieu of drugs. For example, for 30 days, avoid late suppers. Drink wine well watered. Take ginger or anise in very small quantity after the principal meal. No raw fruit at night. Take a tepid bath once weekly. Brief walk each morning. Only if, despite this, a clear recent stomach burden occurred after a feast would a single mild emetic be allowed, early and fasting, with aftercare already laid out. Regimen was also the default where class or distance limited access to apothecaries. Rural households used barley and oat gruels, garden herbs and timing. Townspeople used watered wine and simple pottages. Great houses added clarified broths and controlled menus. In monasteries, the rulebook, fixed portions, silence, post-meal walks, functioned as standing medical advice. Finally, regimen served as the exit ramp after any evacuation. Post-emesis or post-bleeding orders immediately returned the patient to tepid sips, light broths, rest, then gradual foods with no repetition of drastic measures. By embedding prevention into daily life, sleep, moderate exercise and sober meals, physicians aimed to make the quiet alternative the norm. Stable digestion, few crudities, and no need to open either stomach or vein. If you set the medical books aside and picture a small household at day's end, the medieval approach is surprisingly calm. Most of the time, health was kept by ordinary habits. Eat earlier and lighter at night, chew well, walk a little after supper, sleep at a decent hour, keep rooms aired and don't drown the meal with drink. That quiet alternative was the baseline. When people slipped, banquets ran long, sauces were heavy, wine was generous. The remedy wasn't a spectacle, it was a checklist. First came signs and location. If the discomfort was clearly in the stomach and very recent, nausea, sour belching, a coated tongue, a pressure under the breastbone, physicians allowed a one-time early morning response. Start with the mildest steps, a little tepid, salted water, perhaps a brief touch to the fauces with a feather, then stop the moment relief appears. Only robust adults with unmistakable signs might be given a measured spoon of squill syrup. Hellebore sat at the back of the cupboard, used rarely, in tiny buffered doses, under supervision. If the picture pointed lower, retained stools, cramping, the route was downward instead. Lenitives, a mild clister, or just soft foods and time. If heat and fullness led the scene, flushed face, bounding pulse, throbbing temples, opening a vein came first, with the same rules about timing and aftercare. Everything ran on limits. Morning and fasting, never repeat the same day, no cold water afterward, broths, sips, rest, gradual food. The division of labour kept it safe. Physicians judged, apothecaries measured, barber surgeons bled, households prepared and watched. Markets and guilds quietly reinforced caution by standardising syrups and weights and by restricting violent drugs without a written order. Settings mattered. In cities, taverns meant more drink with mouthfuls and late nights. The next day's plan was containment and recovery. At court, rich kitchens created the classic crudities, but there were physicians on hand to keep interventions brief and private, and to advise stewards on slower service and lighter late dishes. Moral voices, preachers, confessors, monastic rules, policed the line between cure and excuse. No making room, no habits, no public displays. Women, children, the elderly, the pregnant and the newly delivered were handled with extra reserve. Regimen first, diluted doses, if anything, often no emesis at all. Underneath it all was a steady idea. Strength comes from orderly digestion, not from emptying for its own sake. Dose made the poison. Stop rules save people from dehydration and collapse. Aftercare, rinses, sips of barley water or hydromel, a small bowl of broth, a short walk later, was half the treatment. And when the stomach settled, life returned to the simple disciplines that made purges unnecessary. Earlier suppers, moderate exercise, clean air, regular rest, unhurried meals. So the obsession with vomit turns out not to be an appetite for drama, but a narrow tool kept in a tidy drawer, used rarely, surrounded by instructions and put away quickly. Most nights ended the same way, shutters closed, hearth low, a light broth if needed, and plans to do better tomorrow. With the house quiet and the stomach calm, the safest medicine was sleep. Good night.